करू नको, बोलू नको, माझा वेबिनार चालू आहे.
Should we start now?
Yes, I think
Ready live?
we should.
Jaya, we are live now.
Yes.
I think we can start. Yeah, we should start.
Learning is a treasure that will follow its owner everywhere. A very good afternoon to all respected seniors, dear friends, and viewers of this webinar. Myself, Dr. Jaya Turaskar, feel extremely honored to welcome you all. This is Amogs Yuva webinar series episode 7, Navigating Gracefully Through Midlife Issues. This webinar is in association with Amogs Midlife Committee, Amogs Medical Legal Committee. So on behalf of me and my co-conveners, Dr. Monica Umbardhan, Dr. Suyoga Panath, Dr. Rashmi Kahar, and Dr. Madan Kamble, I extend a very warm welcome to you all.
Bhavna, there's no audio.
Volume.
There is no
was not
sound,
there.
Bhavna.
Anyway, we have lighted the lamp.
There is no sound, yeah.
Over to you, Dr. Madan sir.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा.
I welcome all for this today's Amogs Yuva webinar series 7. It's my privilege to introduce and welcome our today's chief guest, Dr. Kiran Kurtkoti sir. Everyone knows sir very well. Sir is president Amogs and he is past vice president of Foxy. He was organizing chairperson of Amogs 2024, recently held in Pune.
Madan, it's okay. Madan,
No, sir.
that's okay.
Yes,
That's
one
okay.
minute.
Thank you.
Okay, sir. Okay. Over to you, sir.
Yes. At the outset, welcome to all of you on behalf of Amogs. Our esteemed guest of honors, it's a pleasure for me to welcome Dr. Ambuja Madam, Dr. Pardeshi sir, and Dr. Bipin Pandit. And what can I say about Amogs? That is my own organization. You know, the theme of this year was probably Inspire Inclusion. And Amogs is inclusive to such an extent that if at all you see today's conveners, we have all this, everyone included in this webinar. We have Dr. Suyoga, we have Madan, we have Dr. Turaskar, Dr. Rashmi, Dr. Monica, and also Dr. Sandhya Saran. So, you know, it's a spectrum of everyone who is the chairperson of Amogs. Most of them are included in this webinar, and it's really a great thing for me to be the chief guest of this webinar. Well, today's scientific program also includes many of my friends within Maharashtra as well as outside Maharashtra. We have Dr. Shaijas, Dr. Parag, Dr. Maninder, our very old friend for the past 25 years. Welcome, Maninder. And of course, Vineet and Hara. So what can I say? And Amogs is really pleased to have all of you on this particular platform. And I would wish Dr. Jaya as well as all the conveners a very best wishes for this particular webinar. Thank you so much for inviting me to be the chief guest for this webinar. Thank you so much.
Thank you, sir, for your kind blessings.
Thank you, sir, for all your kind wishes. It's a great honor to welcome an exemplary teacher as a guest of honor today. Dr. Ambuja Choranur, madam, a very kind, compassionate, loving, caring, and supportive lady who has been research committee chairperson of South Asian Federation of Menopause Society, and she also had been president of Indian Menopausal Society 2021 and 22. She has retired as an HOD, OBGYN Department, Usmania Medical College, and now is visiting professor at Savita University, Chennai. We know her for her enormous work as Vice President of Family Planning Associations of India, and she is a faculty and resource person for DNB exams. We welcome you, madam, and we would surely like to hear you on this occasion. Welcome,
Thank you very much, Rashmi, for your kind words. Respected Kiran Karkoti sir, President Amogs, Dr. Bipin Pandit, Honorary Secretary, Dr. Rajendra Pardesi, Dr. Rashmi Vardha, Dr. Parag, good friend of everybody, Dr. Maninder, and all Amogs members, dignitaries, and distinguished guests. Good evening to all of you. Thanks for inviting me to be guest of honor for today's webinar. I'm saying this webinar series from the beginning. They are quite educative and very, very interesting. And today's topic really wonderful. That is navigating gracefully through midlife issues is a very good topic. But I'll tell you, it's a challenging topic too. I'm sure that it is the brainchild of our president and the secretary who have done it. At this point of time, I remember there was a film that was released by our controversial director Mani Ratnam. The film's name is Yuva. That portraying the midlife issues through three young protagonists. Each had gone through, he has shown everything in the film, what are all the issues in coming up from adulthood to the midlife, and he said what are all the challenges they face, that is the identity crisis, career ambition, relationship issues, family, health, and mortality. These are the things which are projected. This is such a wonderful film it is, though I don't know whether it has come out or not. Today's webinar also is going to be such an interesting one, waiting to hear all the experts to speak about that one. And once again, thank you very much for inviting me for this webinar, and all the best to Amogs. And forever we expect you to produce such a wonderful webinars. Thank you all.
Thank you.
Thank you, ma'am, for the wonderful words of blessings for all of us. It really means a lot for all of Amogsians. It is my proud privilege to introduce Dr. Rajendra Singh Pardesi, sir, who is an immediate past president of Amogs. He has been the past chairperson of the Food and Drugs Committee also. Sir has been a constant support for all of us at Amogs. He is an ever smiling, ever supporting figure. We welcome you, sir, for your kind words of wisdom.
Good evening, everybody. Respected Chief Guest, Dr. Kiran Kortukoti, sir, our President, Amogs. Guest of Honors, Dr. Ambuja Choranur, Dr. Bipin Pandit, and dignitaries, Dr. Parag Biniwale, Dr. Pushpa, Somanshi ma'am, Dr. Saijas, Dr. Hara, Dr. Maninder Ahuja, Dr. Kavita Barnwal, Dr. Suman Sinha, Dr. Sujit Konkar, Dr. Vinit Mishra, Dr. Varsha Lahade. I am feeling proud and honored to be a part of this great event. As Dr. Ambuja, Dr. Parag, Dr. Maninder, Dr. Saijas, they are all stalwarts and they are eminent faculties, hardcore faculties in the field of menopause. And from IMS also. We are all working, but they are hardcore faculties. So I'm really proud and honored to be a part of this webinar. First, I wish to congratulate Dr. Suyoga Panat, Dr. Rashmikar, Dr. Monica, Dr. Madan Kamble, and Dr. Jaya Tulaskar for organizing such an academic and practical webinar on midlife issues in women. menopause transition and consequences if not treated has to face that woman lifelong, which may affect their quality of life also. This all knows. Hence the topic that MHT, genital urinary syndrome, POP, SO are really important in women's life, mostly in midlife. I will suggest organizers to add some topics related to osteoporosis and bone health in next webinars, in the next series, because that is also really not emerging, but really important issues. I wish every success to Dr. Rashmi Kahar, Dr. Sujit Kondkar, and Dr. Varsha Lahade for their future endeavor in FOXI as chairpersons they are contesting. Wishing every success to this webinar. Thank you so much for inviting me. Thank you.
Thank you, sir.
Thank you very much, sir, for your kind words and encouraging words indeed. And we all wish that Rashmi, Sujit sir, and Varsha madam should win the elections. I now feel privileged to introduce Dr. Bipin Pandit sir, who is our Secretary Amogs, and he was the past Executive Council member of Maharashtra Medical Council, Vice President for 21-22, past President of MOGS in 2018-19.
I think that's enough, Peter.
We solicit your
Let's not
blessings
waste
for
time
this
in
webinar,
this.
sir.
He is voice
Thank
of
you, Dr.
Amogs.
Kiran Kuttakoti, our president. I don't have any vices. Dr. Kiran Kuttakoti, our president, Dr. Pardesi, past president, Dr. Ambuja madam, all the great dignitaries. I must congratulate Rashmi Kahar for the excellent arrangement, and he's extremely hardworking, and you can see the success of the seminar and the topics what he has. At the same time, the great faculty, Dr. Parag, Dr. Sujit, Dr. Pushpa, Dr. Tara Patnaik, Dr. Subhan Sinha, Dr. Kavita, Vineet Misra ji, and Varsha. I'm sure this is going to be a treat for everybody, for all the midlife problems. And as Dr. Patrisi said, osteoporosis is one of the jwalant problem ahead. And many ladies at this age, they have fractures because of osteoporosis. So we should also keep a topic of osteoporosis along with other problems of health. Thank you very much for giving me opportunity, and all the best for this.
Thank you, sir.
Thank you so much, sir, for your gracious presence and blessing this webinar. Amidst of hustle of career in our 40s, we may neglect self-care. So during this transition, it becomes imperative to maintain a healthy work-life balance. So moving on to our first important and very interesting session, that is midlife work-life balance. Bhavna, please share first session slide. So for this session, we have esteemed speaker, Dr. Shaiju sir, and our respected chairperson, Professor Dr. Pushpa Somvarshi madam. So with great honor, I would like to introduce Madam. Madam is Professor and HOD OBGY at PDMMC Amravati. She is PhD guide in faculty in many national and zonal and state conferences. She was past President Amravati OBGY Society. She has been awarded with many awards like Pudhakar Samman Award, Amravati District Best ICTC Award, Amogs Ratna Award for her efforts towards women's health in India. She is the one who has popularized NDVH in Amravati region. And there are many publications in national and international journals to her credit. So I welcome you, ma'am, and I request you to please introduce our speaker.
Hello, good evening all. It is my proud privilege to introduce today's speaker, Dr. Saijesh. He is currently chairperson Midlife Management Committee of FOXI, Joint Secretary of Kerala Federation of Obstetricians and Gynecologists, past chair Research Committee of KFOG, and he was president of Kannur OBGY Society. He is having his own fertility center, and he is specializing in not only in fertility practice, but also he's a very good laparoscopic surgeon. He has got plenty of awards in his name, like Shailaja Pandit Women Empowerment Award, International Traveling Fellowship Award, Foxy Superstar Award, Kaminira Orator for 2018, Foxy Durusha Youth Trophy, Dr. Chitrahara Preventive Oncology Award, Smriti Mailan Award for 18, as well as in 2020, and many more. And let me tell you certain things. He is the person who will be the best person to talk about work-life balance, not only midlife, but every time. I don't know how many of you are knowing about his other qualities. He is not only a excellent gynecologist, but he is very fond of singing and he sings very well. He is excellent photographer also. And he is a very good sports person as well. So over to you, Dr. Saitis.
Dancer too. He's a good dancer too.
Okay, that was something I was
Thank
not
you.
knowing.
Thank you. Thank you. Thank you. Thank you so much for those kind words. Shall I share my screen? Can you just enable a share screen for me?
Bhavna, please do the needful.
I've done, ma'am.
Okay, yeah. Now it is done. I hope my slides are visible and I'm audible.
Yes, sir.
Absolutely.
Yeah. First of all, a big thank you for this opportunity to be a part of this very wonderful Amogs Yuva webinar series. Thank you so much, Rashmi, for coordinating. And incidentally, Rashmi happens to be my better half's name also. So whatever work-life balance I maintain, I think credit has to go to the Rashmi at home, and credits to the wonderful work to this Rashmi for organizing this wonderful webinar, calling up people, and that's what maintaining a balance is probably all about. Wonderful to see the esteemed guests of honors, including the chief guest, Dr. Kiran sir, whom we've been knowing for years together. The esteemed guest of honor, Dr. Ambuja madam, whom I had the opportunity to work with when she was heading the Indian Menopause Society. Dr. Rajendra Pardesi sir and Dr. Bipin Pandit sir, both mentor-like figures in Foxy throughout the journey. Hats off and kudos to all the conveners, Dr. Monica, Dr. Suyoga, Dr. Reshmi, as I already mentioned, Dr. Jaya, as well as Dr. Madan. Special thanks to Pushpa Madam, the chairperson for the session, for those kind words. And for the speakers for the coming session, Parag sir, a real mentor-like figure, Dr. Maninder Madam, who got this midlife management committee started a few years back, and Dr. Patnaik sir for all the wonderful work that he has done for Foxy, and the chairpersons Dr. Sujit, Dr. Kavita, and Dr. Suman, and special regards to Vineet Misra sir and Dr. Varsha Lahade, both very important and known people throughout this journey in Foxy. So on that note, let me get started. I breathe greetings from my Foxy team, led by the vibrant President, Dr. Jaideep Tank, as you all know, Dr. Madhuri Patel, Madam, the first ever Women Secretary General of Foxy, and Dr. Janmejaya Mohapatra, the Vice President in charge of the Midlife Management Committee of Foxy. I also bring greetings from the Kerala Federation, of which I'm heading the research committee as a chairperson, as well as this small and wonderful society called the Cananur ONG Society, a group of 130 plus members doing a lot of good work, not just on the academic front, but on the social front too, attempting to make a difference. Now, I'm talking on a very, very interesting topic, which is work-life balance. I think it's a relatively out-of-the-box topic. Rather than being useful for imparting patient care, I think it might be much more useful for yourself in your lives. I think even when I'm giving a lecture on this, it's not that I have mastered how to achieve this balance, but I think we are all learning. So we can all learn from each other and try to improvise on achieving this so-called entity of work-life balance in midlife. We look at a few tips and tricks. But before we actually enter into work-life balance in midlife is probably the most important part of this lecture. So if you understand midlife a little bit, I think you'll be able to get an idea of how to achieve the balance, because you need to know what you're dealing with midlife to ensure that you achieve the right kind of balance for the midlife that you are going through. Midlife, as you all know, traditionally being defined as an age bracket between 40 and 60, but the definitions are expanding, and we understand today that it is not just about the age that you belong to. It is about that phase of life where you need to manage two other generations on either side. One is your children, who probably are growing up, who are almost reaching their teens or have already become teens or just crossed that age group on one side. And on the other side, you have the geriatric age group to manage, which is represented by your parents or your in-laws. And you are in between. And that is why this midlife is called by a very interesting name. And what is this generation called? Any guesses from the people who are here? It's very obvious from the picture, I suppose. We call it the sandwich generation. Okay. So rather than a sandwich, I generally find it interesting to compare it with the brake pad of a vehicle, because if the vehicle has to run well, I think the entire brunt of the load on how smooth a vehicle runs or not basically comes on the brake pad. And just like this generation in midlife, I think you need to ensure that you don't get worn out in the process in an attempt to ensure that your vehicle, which is the family, runs well. Okay, so do take care of yourself. It's all about self-love and how you take care of yourself. And that's a woman in midlife. You don't have to look at the slide. You just have to look at yourself in the mirror and you understand how multitasking. Now, is this just applicable to women? It is also applicable to men who do a lot of multitasking and who attempt to fulfill a lot of roles in life. Now, because we deal in majority with women, a woman in midlife is balancing a lot of aspects. She has a lot of roles to fulfill as a mother, as a daughter, as a daughter-in-law, as a wife, as a teacher, as a finance manager, and the major head of the household. Now, irrespective of be it a man or a woman, on an average, a man or a woman in midlife is expected to fulfill almost 5 to 8 different roles. Okay. And that is why achieving a balance between work and life in this particular age group becomes even more challenging. Now, irrespective of whether you're religious or not, the closest resemblance is to Lord Durga. As we go on, it's not all that bad in midlife, right? Because if you look at the good things about midlife, you understand that you are probably at the peak of your career. If you look at your earnings, they too are at their peak. You're fulfilling multiple roles in life. On an average, I told almost 5 to 8 roles. Might be a little bit more lesser, might be a little bit more than 5 to 8 for a few. And you're able to do what you dreamt of doing all your life because you have money, you are at the peak of your career, and you're all set to do and to fulfill your dreams. So those are the good things. Now, if you are comfortable managing these multiple roles and achieving a balance, you tend to be really happy. Otherwise, not so happy. Now, a lot of equations within the family actually changes in midlife. The equation with your partner changes. Randomly, a woman in midlife was asked, "How's your headache?" And she instantly told that he has gone to office. Sometimes, be it a man or a woman, if you are too dependent on your partner, you become one of the primary stress factors for your partner. It could be a very dependent man who would probably require the toothpaste to be placed on the toothbrush by his partner so that he brushes. Only when a bath towel is given to him, only then the morning routines will happen for him. It could be It could be the story of a very dependent wife on her husband also causing similar kind of problems. Can we mute everyone here? Yeah. So add on to that is the declining partner's health. And if you need to give more caregiving to your partner, that really creates a lot of imbalance. Then issues of marital disharmony, divorce and breaking up with a partner. And when you feel that you've got rid of one, then you're thinking of another one, then you find that adjusting from an old to a new partner becomes even more difficult. So these are the changing equations that goes wrong with your partner in midlife. With your children, the problems could be either way. One is the empty nest syndrome, where children have been with you and now they need to move out for better education, for their higher studies, or for their job, or the other way around. They have been in boarding schools all throughout these years and now they come back home, and managing them becomes very difficult because you're not used to it. And then unfortunate events like the death of a child, and for a in subfertile couple in midlife, they understand that a biological parenthood may not happen for them. Everybody else is celebrating with their own pregnancies or their child's or their daughter's pregnancies and all that. And that could be just like adding fuel to the already existing fire. And then the biggest task of parenting a teenage child, you all know how difficult it is. So that could really add a little bit more fuel to the fire that is already existing. Now, the changing relationships with your aging parents, siblings, and in-laws, parents' health problems on one side, that thought process, whether you are actually able to care for them or are you getting stuck at work and you're unable to care for them. Those kind of dilemmas that happen in your head can really trouble you. And then the problem with the in-laws seems to be never ending. If you watch the daily serials that happen in most of the channels, they all portray the mother-in-law and the daughter-in-law in this manner. There is always suspicion. There is always some kind of hatred, and somehow I think we are almost getting into a conditioned belief that this relationship between a daughter-in-law and a mother-in-law cannot really work out well. So that could be a stressor for those people who are actually suffering. Now, those are the things that actually could trouble you. Now, is it just your own problem, or are happiness levels going down across the world? Now, if you look at the happiness levels across various age groups, you will find that the happiness curve assumes a U shape. Okay, and this is based on a research that was conducted by David Blanchflower in men and women across 132 countries. They found that people are very happy when they are young. People are also happy when they are old, and unfortunately, the happiness levels hits the rock bottom when you are in midlife. Now, this may not be applicable to all. People who have found out this entity called midlife happiness doesn't really have to hit the rock bottom as far as happiness levels are concerned in midlife. But if you have not sorted out your midlife problems, and if you're really getting confused fulfilling these multiple roles, that's when you tend to agree to this U curve of happiness. Now, whether it is true or not, there is always a mixed opinion from across the world. But understand that in a country like United States, from where we have reasonably good data, almost 26% of men and women seem to be suffering as far as their happiness levels are concerned. Not all go into midlife crisis, but people are suffering. 26% would mean almost 1 in 4. And if that is the state in the United States, what do you think about India? India doesn't seem to be a very happy country in general. If you look at the happiness index, we are somewhere at the rock bottom of almost 127 or 128 position, depending on the survey, based on the survey that was conducted recently on the happiness index levels. So that's where we are. Now, coming on to the specific entity of achieving a work-life balance. Now, the first question that you need to ask yourself is, we understand that achieving this balance is a struggle. You're balancing the responsibilities of your work day, your home life, and the relationships with your family members and other loved ones. So does a work-life balance exist? Can we achieve it? Are the two important questions that you need to ask. Now, one thing I want to tell you is, what is your work-life balance? Is it defined by the society, or is it defined by you as an individual? I would say it has to be a very customized one. And that customization will have to come from within yourself. You will have to decide what your work-life balance is going to be. That means you can decide on how many hours that you're going to spend time with your work. Okay. Do you believe in that kind of a practice where you want to take up all the responsibilities and you want to give work a priority and your family life becomes a lesser priority automatically? Are you okay with that? These are questions that you will have to ask. Or are you that person who finds a lot of happiness in leaving your child, dropping your child to the school every morning, and your happiness levels would definitely increase if you can start your day that way? Then I think you should definitely find out some time to focus on your family life and to spend more time with your partner and your children if you're thinking that way. So work-life balance for a person needs to be defined and defined by that person itself, and it should not be based on the norms that the society sets for you. Fine. On that note, this would be the difficulty, right? If you concentrate a little bit more on the career, then obviously salary gets higher because you start earning well. And somewhere you tend to lose on maintaining this balance because your family life gets affected. And that's where it becomes a very, very difficult equation to manage. So you will have to define what your work-life balance is going to be. Now, are there some tips? Yes, there are some tips. And one of the most important tips is to learn to say a no. Learn to say a no to things which come lower in the priority list for you, or which you are unable to accommodate within the schedule that you have set for yourself. Okay. And remember that saying a no is not that easy. Learning how to say no can be one of the hardest soft skills for any dedicated professional to learn and put into practice. So that's why this becomes the most important tip to achieve a work-life balance. So if you decide that which are the things for which you're going to say yes, okay, if you're committing for a talk on every day of the week, and then you say that you don't have time to do your work or spend time with family, then I think you will have to say a no to a few webinars and get little bit more selective in choosing your time to spend for academics. Okay, so that was just an example. Okay, fine. Now I have also said a no to a few other talks which had to happen on this week itself, so that I have a little bit time for myself and a little bit more extra time for my family too. So learning to say a no is probably the most important thing in life. Okay, so that's important in setting boundaries. Tip number 2 is to take a break. Okay, it's like having a little bit time for yourself. As you would have seen in the movie called Three Idiots, there was somebody who was the principal who was going for a power nap, 7.5 minutes, and he ensured that all the less productive work like yeah, a shaving of his facial hair was done during that time, so that he utilizes the time a little bit more better. Now, even a 30-second micro break when you are at work can do a lot to actually improve your productivity. So rather than getting stuck with work continuously, just take a walk around for some 5 minutes and get back, and you'll be much more fresh and you'll get more productive. So taking a break is the tip number 2. Tip number 3 is asking for flexibility. Okay. Is it this kind of flexibility that I'm talking about? No, it's not really about the physical flexibility, but it's about the flexibility in your work hours. So that's why I was telling, if you're that person who finds a lot of happiness in dropping your child in school every morning, and that's the way in which you always dreamt of getting started with your life in midlife, then you should consider shifting your start time of your OP to maybe some 10 o'clock, 11 o'clock, so that you can do what you want in the morning and then you can get back to work on time. Okay. So that kind of flexibility, if your organization or your clinic or your own setup allows, then there's nothing which can be better than that to achieve the work-life balance. So flexibility in work hours is something which even the bigger hospitals, bigger corporate setups and bigger organizations are actually looking at, so that people, their employers get more happy. Fine. Now, the next tip is this, that you don't have to be perfect, no? Let go of perfectionism. When you are growing up, no, there is something called an internal critic. This internal critic, which is there within you, is what helps you aim for bigger things in life. You always wanted to be perfect, and your internal critic kept on correcting that. So when you did things in a suboptimal manner, the internal critic within you just woke up and said that no, 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 this much perfectionism is not enough. You need to push yourself a little bit more harder. You need to achieve those extra grades. You need to go higher up in the grades by achieving those extra marks. So that was the internal critic in you, which helped you to dream big when you were growing up. So that gave you an evolutionary advantage at that point of time, at an age when you were growing up. But now you are in midlife, no? So the entire story changes. The same internal critic which gave you an evolutionary advantage when you were young is now giving you problems. You will start comparing yourself with how you used to be when you were young. That means that time you are physically in a much more better state. So you could probably run 100 meters in probably 12 seconds or 15 seconds if you were an athlete at that point of time. And now you even have difficulty in getting up from a chair after a prolonged episode of sitting. Okay. So you tend to compare yourself with your younger times. And you also tend to compare yourself and your achievements with the achievements of your colleagues. Now, this becomes a perfect recipe for suffering. So the internal critic, which once upon a time when you were young, gave you evolutionary advantage, now becomes your recipe of suffering and your recipe for sadness in midlife. So just put that internal critic to sleep. You really don't have to do things that perfectly in midlife, even if you're managing those 5 to 8 roles that midlife gave you in a reasonably well manner, not too perfectly well. It is still okay. It is still okay. Give yourself some time and you will adapt and adjust to that. Because if not, that becomes the reason for significant pain in midlife. Fine. Now, how to move towards midlife happiness? One is to normalize it to an extent, because there are many things that you have to do, and a lot of people in midlife have a little bit dip in their happiness levels, and it's a near universal phenomenon, and you're just one among them. So even if you're not feeling too happy and excited every morning, it is still okay. Give yourselves some time. And then that was a story about the internal critic, which I already mentioned. I hope that has been carried on well. And just telling yourself that I don't have to be better than anybody else. I just have to improvise and adjust and do things which I am capable of doing at this age. That is what need to be the content of your self-talk. And that reflects and ultimately turns into self-love, when you can be kind to yourself with whatever abilities as well as disabilities that you have in midlife. Okay, so you don't have to be better than anybody else. So other than these aspects, which really can give you trouble as far as the mental health is concerned, you need to be really taking care of your physical health too. There are only two important things to ask in midlife. One is what do you eat, because you need to eat right in midlife, and how physically active you are. You will find a whole lot of diets and all that. Okay, now we understand that the calorie restricted diet seems to be working well. The balanced diet, which is called as a Mediterranean diet, seems to be working well. Keto diet came with a bang, but now we understand that it is not an ideal diet because it causes too many problems as far as your heart and kidney is concerned. It's causing people to end up with acute cardiac events and dying. It is causing their kidneys to fail. So keto diet is almost out, and you can start believing in a balanced diet or a calorie-restricted diet if you want to get healthier. As Hippocrates said, let thy food be thy medicine. My favorite quote would be, eat just to fuel your body, not to feed your emotions. So if in case you're not feeling well up there, not feeling well mentally, kitchen is the last place where you should go, because when you're not feeling well up there, you tend to overeat. Okay, so eat just to fuel your body. Your calorie requirements really comes down in midlife. So eat accordingly. Is the moral of the story. And then, unfortunately, the only muscles that are working these days are the ones at the fingertips with which you work with your laptop or your mobile. And then the muscles that take the food from the container to the oral cavity. And remember that just like tobacco and alcohol kills people, physical inactivity and being on a faulty diet is killing almost equal number of people. So just remember this. Based on physical activity in midlife, you need to take care of a few things. Aerobics is something which we all advise and probably do. We are telling every woman to walk for around 30 minutes for them to be in good health. So that's aerobics for you, basically. It could be any form of aerobics, and walking, brisk walking is one such. But very importantly, a man or a woman in midlife need to think of these entities. One is endurance training. The other is resistance or strength training. Is something that you need to focus because they are two separate entities. For want of time, I'll not get into the details. You also need to think of these group of exercises which work on flexibility, posture, and balance. I repeat, flexibility, posture, and balance, because these are the things which put together prevents that catastrophic event in midlife for a man or a woman, which is a fall. Okay, so work on these headings, and then your physical activities are on track. So 30 minutes per brisk walking per day is good enough as far as your cardiorespiratory endurance is concerned. And it also helps you to prevent a chronic disease from happening. Okay, it reduces the risk of a chronic disease from happening. But if you want to prevent weight gain, that exercise schedule need to be prolonged to 60 minutes per day. And if you really want to lose weight, it has to be almost 60 to 90 minutes per day of good activity. And then you're on the right track if you're on the obese side and you want to lose weight. Okay. So on that note, there are a lot of, those are my social media handles, and we run a lot of awareness campaigns there. So it is a pleasure to talk to you all. Remember that be it a man or a woman in midlife, I think fulfilling those multiple roles, I think you all need to feel really proud of yourself, because I feel if you are a midlife man or a woman, and if you're fulfilling this many roles, you are a superwoman and a superman. Thank you so much for such a patient listening. It is a pleasure to be here. Thank you, Amogs, for this wonderful opportunity.
Thank you so much, sir. It was very excellent and practical talk, sir, with great tips and take-home messages. And now I would like to request Dr. Pushpa ma'am for her remarks.
Very excellent talk, Dr. Saijesh.
Thank you, ma'am. Thank you.
Regarding your tips, they were really tips which are going to be helpful for everyone who is listening, and we can pass it on to our patients and our acquaintances also. I would just like to add something regarding this. You should rather prioritize whatever you love most, you prioritize, whether it is your work or your family. And another thing is, don't think that you are indispensable. So don't try to be. So at workplace as well as at home, it is better to delegate some of your work. So have faith in your fellow or colleagues and your family members also, that they can do as good as you're able to do it. So that is another thing I think we should keep in mind. And one more thing is give time to yourself. That is another thing. And Dr. Sajas has covered not only physical well-being, but mental, psychological, social, everything in such a short time. He has given us very good tips, excellent tips. Good.
An absolute eye-opener talk.
Thank you. Thank you so much. The IPL is getting started, and Dhoni feels that he is also not indispensable. That's why he has handed over the captaincy yesterday to a young guy in Rituraj Gaikwad.
Yes.
And Dhoni is probably going to have a blast this year without the responsibilities of a captain. And that is probably the way in which we should all look at midlife.
True.
Is he into midlife?
I would like to request Ambuja ma'am for her views and remarks.
As is excellent as it is always.
Thank you, madam. Thank you.
Adding on one more thing, for everybody has said, I think meditation and yourself going down to God That's very, very important because, midlife, at midlife gives a little pressure. Means God means you need not have, go to the temple, do something like that. No, keep yourself silent for some time. That's what is the madam told. It is take your own time. But praying God is always, it is something soothing. Definitely it is good. Maybe one more addition to all the points what you had. And it is really wonderful that you covered everything within a short time. That's very good.
Thank
Very, very nice.
Otherwise, I would not have been able to go. So it's a blessing in disguise. Yeah.
Yeah, that's
And
great.
wonderful talk.
That is great.
Yeah.
Thank you, madam. Thank you.
Thank you so much, respected chairpersons and sir. Now for second session, over to you, Dr. Madan sir.
Thank you, Dr. Jaya. We will be moving on to session number 2. We have a great speaker, Dr. Parag Biniwale sir. And for this session, I welcome Dr. Sujit Konkar sir to chair the session. Yeah. Would like to introduce Sujit sir. He is from GMC Aurangabad. He has done basic training at Dr. Bimal Sahani's sir at Aurangabad. He is FMF certified for 11 to 13 week scan. He is FOXY recognized. He has Center for Ultrasound. He was Secretary of Society of Fetal Medicine, Marathwada chapter. Then he's interested in advanced fetal ultrasound, and currently he's chairperson of Fetal Medicine Committee, Amogs. He was past chairperson of Amogs. I request Sujit sir to deliver the talk. Welcome, sir.
Thank you, Dr. Madan, for nice introduction. It's my honor to introduce and welcome Dr. Parag sir on this webinar. He is senior consultant at Pune, PG teacher and unit head at Kamala Nehru Hospital, chairman-elect Indian College of Obstetrics and Gynecology.
Sujit, thank you. Don't waste time in that.
Okay,
We can
sir,
have
welcome.
more time for discussion.
Yeah, okay, sir. Welcome. Over to you, sir.
Thank you. May I share my screen, please? The host need to enable me. Good evening. I bring greetings from Pune, and it's indeed a pleasure to be sitting in the Yuva Amogs webinar series. Thank you, Rashmi, for considering me as Yuva. Pleasure to have Dr. Ambuja and Dr. Maninder, who are very dear friends for many, many years, listening to me. In fact, that's a little difficult part because they are the ones who have led Indian Menopause Society where it is today. At the outset, thank you, President Kiran, Monica, Suyoga, Rashmi, Jaya, and of course, Madan for asking me to speak here. It's a difficult task, especially after to speak after a brilliant Shaijas, but I'll try to do my job well. The topic that has been given to me is about menopausal hormone therapy. All right. So in next 15 to 20 minutes, we'll talk about the menopausal hormone therapy and how we are going to use it. All of us know that menopause is a universal event for each and every woman. So a woman who starts menstruating at some point or the other will land up in menopause. So it's a natural thing for a woman. So the question that comes to mind of some people, why at all to treat menopause? Let's not forget that there are millions of women who are still suffering. In the average age of menopause in India is around 47 years. Maninder, correct me if I'm wrong. This is your data that I'm showing.
Yeah, right.
It also means that 1/3 of life of a woman is spent in a hormone depleted menopausal phase, and that is what bothers her, and it is what is responsible for so many issues which crop up because of estrogen deficiency. So we do get to see women who come to us with disturbed sleep, mood disorders, osteoporosis. They have issues related to the cardiovascular health, Alzheimer's disease. There's increased risk of breast cancer, and of course, obesity, metabolic syndrome, etc. are very well known problems in this age group. So before I begin, these are some of the terms that we all should know. Traditionally, we've been calling HRT, that is hormone replacement therapy, but now we prefer to call it as MHT, that is menopausal hormone therapy. And HRT is something which is reserved for women who have premature ovarian insufficiency or premature menopause. When we talk about menopausal hormone therapy, the first thing we have to understand is we must have a good dialogue with the woman who's asking for menopausal hormone therapy, and it has to be documented well. So what should we discuss? So we should be talking about the benefits. We should be talking about the risks and side effects of the therapy, available therapeutic options and the options which may be more suitable for her. The way treatment will be monitored. Please understand that menopausal hormone therapy has to be monitored very, very closely. We should also discuss about how long the therapy might be used, and not to forget the economic consideration. There are some preparations which are really expensive, and all these discussion would result into an improved compliance to the treatment. So when we talk about menopausal hormone therapy, there are, of course, various hormones which are available for our disposal. We have estrogens, progestogens, androgens, and even tibolone. Coming to estrogen, so natural estrogens are the ones which are considered in the menopausal hormone therapy. So we do have conjugated equine estrogen, which we've been using for years together, and now we have 17-beta estradiol, estrone and estriol in our kitty. The synthetic estrogen, that is ethinyl estradiol, which is very, very potent, is meant for oral contraception and not for menopausal hormone therapy. And why do we think that lower doses should be given? Because we always believe that we should start menopausal hormone therapy at a smallest possible dose, because the benefits of hormone therapy can be achieved with a small dose, and possibly the side effects will also be less. So efficacy in prevention of osteoporosis is not compromised if there is symptomatic relief, and if it is going to have a potential long-term health benefits, it is worth considering smallest possible dose. Of course, in some women, we would prefer higher doses, and which includes women who are prone for severe osteoporosis, those who come to us with premature ovarian insufficiency, and women who do show predominance of psychological problems like climacteric depression, etc. Coming to progesterone in MHT, why it is important? It is important to administer progesterone to counteract the effect of estrogen. The progesterone in menopausal hormone therapy, for years we've used medroxyprogesterone acetate, and now we know that it was the culprit for more chances of breast cancer. So then we prefer natural progesterone, and we choose between natural progesterone or micronized progesterone and dydrogesterone, which are metabolically friendly. They are neutral onto the breast. It has improved bioavailability when taken orally, especially the dydrogesterone, and it does not alter the moods. In some women, we may even prefer LNG intrauterine system. Women who come to us in perimenopause and are required to give hormones, we can consider LNG IUS. In perimenopause, women who are desirous of contraception or women who have abnormal uterine bleeding, LNG intrauterine system can be considered. And women who do experience some side effects with oral progestogens, don't forget that you have LNG IUS at your disposal. So when we think of prescribing menopausal hormone therapy, first of all, we have to identify why the woman wants menopausal hormone therapy. Rule out contraindication, counsel her, and find out how her suffering is because of estrogen deficiency. Timing is very, very important, and there's a concept called window of opportunity where women come to us in perimenopause, and that is the time we should try and talk to them about menopause management. So early start is important, and it helps in maintaining the estrogenic benefits. So selecting the type of estrogen, type of progesterone is important. A route of therapy has to be decided with discussion with the patient. Minimum effective dose is to be started, and of course, if needed, we can always increase the dose. Risk benefit analysis is something which is extremely important, and I'm coming to it in a while. We must tailor evaluate response. No mandatory time limit, and follow-up is mandatory, and it should be done annually. Of course, avoiding generalized prescription is important. So which are the situations, or what are the benefits of menopausal hormone therapy? First and foremost, whenever any woman comes to us with vasomotor symptoms, MHT would give a good relief within a span of about 4 weeks. Of course, women who suffer from osteoporosis, MHT will help increasing the bone mineral density. There would be decreased risk of fractures. It is recommended for women with early or premature menopause. And it is also seen that women who experience sexual or urogenital symptoms, women who come to us with vaginal dryness, vaginal atrophy, etc., MHT would give them a good relief. So this is a hormone therapy benefit risk analysis, and I've taken it from the Indian Menopause Society. So whenever we get a woman who comes to us seeking help for menopausal hormone therapy, find out what are her symptoms, what is her age, whether she's into menopause for 10 years. If she's more than 60, if she's more than 10 years into menopause, MHT is not meant for her. So a woman who's less than 60 and less than 10 years into menopause, consider circumstances where MHT should not be used. So we must avoid it. If she's suffering from stroke, TIA, pulmonary embolism, venous thromboembolism, if there is a history of breast or endometrial cancer, active or treated, active liver disease, and unexplained vaginal bleeding, we would still avoid it. If these factors are not there, we should also inquire about diabetes, hypertriglyceridemia, active gallbladder disease, and increased risk of breast cancer, CVD, and of course, migraine. If she suffers from any of these, we may consider other options. If all these factors are negative, evaluate cardiovascular risk. If it is high, consider other options. If it is acceptable, evaluate breast cancer risks. If it is acceptable, then think of MHT. Now, if the uterus is present, we would give her estrogen alone. If the uterus is present, we would give her estrogen plus progesterone or tabalone or an LNG-IUS along with estrogen. And if she's hysterectomized, estrogen only should suffice. So there are some important points we have to consider, like when to start, what therapy, tackling the side effects, how long to give, and very importantly, when to stop. So when we start MHT, we must explain the woman how she's supposed to take it. She has to report at 1 month and 3 months in the initial phase, and then every year. She should be told that she may experience unscheduled vaginal bleeding, which is typically seen in first 3 months, and she should not expect magic with 1 or 2 pills. It usually takes about 3 to 4 weeks for control of symptoms. So whenever we are prescribing estrogen, they can either be oral, transdermal, or vaginal, and progestrogens can be oral, vaginal, and intrauterine. So when the uterus is absent, continuous estrogen can be given. So there is no tablet break, and obviously there's no question of bleeding. When the uterus is intact, we need to discuss with her whether she would like to have bleeding intermittently. If so, then we can give her continuous sequential MHT. So estrogen is given all through the cycle, add progesterone for 14 days, allow her to bleed, and then the therapy can be continued for a longer duration of time. And if she's not interested in bleeding, she can obviously be administered a continuous combined MHT where she takes estrogen and progesterone every day. There are certain problems we should anticipate and we should counsel her. First and foremost is unscheduled bleeding. Second could be insufficient symptomatic response. So here we may alter the dose. If we've started with the lowest possible dose, we may even increase the dose, change molecule, or even we can consider alternative therapies. Now, thromboembolism is something which we are always concerned. And of course, there are certain risk factors like smoking, increasing age, obesity, and oral MHT. But please understand that pregnancy and postpartum period are much more severe risk factors for thromboembolism rather than MHT. So population screening for thrombophilia is not indicated before using MHT. Stroke is again one condition where MHT has to be used very, very carefully. So think twice before administering it. And low dose estrogen therapy and transdermal route may not increase the risk of stroke. So this is something which we have to keep in mind. Similarly, coronary heart disease. Now, there was a time, I'm sure Dr. Ambuja will also remember that in the 90s, we all used menopausal hormone therapy as a cardioprotective, but it is not considered anymore. So any woman who comes to us after the age of 60, MHT is something which should not be administered to her. Similarly, there's always a concern about increased risk of breast cancer. And here we have to understand that there would be one extra case out of 1,000 women if it is administered to a women in the age group of 50 to 59. So we must avoid MHT in women who are at severe risk of breast cancer and in breast cancer survivors. But otherwise, we should counsel the woman and give her MHT if she needs so. Coming to the endometrial changes. Now, estrogen alone therapy will certainly lead to endometrial hyperplasia, and it may also lead to CA endometrium. So progesterone is something which has to be added in order to prevent hyperplasia whenever we are supplementing estrogen therapy. And of course, the risk of gallstones, cholecystitis, and cholecystectomy is increased with oral MHT and combination MHT. So we have to keep in mind all these contraindications before we prescribe. And there are some situations where we have to be very careful. Migraine, superficial thrombophlebitis, women who have gynecological conditions like fibroid and endometriosis, please note that they may show flaring up of these diseases during the course of MHT. Very important point is when to stop treatment. Now, if the migraine appears for the first time or if the headache gets worsened, if there is blurring of vision or any symptoms suggestive of vascular occlusion, if there is jaundice, significant rise of blood pressure, we must stop MHT right away. And if you are planning some other elective surgery, MHT should be stopped 4 to 6 weeks prior to the surgery. It is important that we do a close follow-up, and after 1 month, the woman reports to the clinic and we find out how useful the MHT has been, and if she has noticed any side effects, check her weight and blood pressure, and after 3 months, she should be called again to assess effect and compliance. The Indian Menopause Society in the year 2020 has very specifically said about the duration of therapy, and extended use of hormone therapy is a shared decision between the woman and the physician. So one of them should not decide what the other person should do. And stopping MHT can be done abruptly, or even the dose and duration may be tapered gradually. Coming to the duration of therapy, and as I said, it is the woman's decision as to how long the therapy has to continue. But in some women, we would certainly recommend that if feasible, they should take the therapy for a longer duration of time, especially when they have premature ovarian insufficiency or if they are at higher risk of fractures. How do we monitor these women? Of course, apart from clinical examination, we should do all these basic investigations annually. Pelvic ultrasound has to be done every year. Mammography is recommended yearly. Pap smear should be done every 3 years. And if you're doing co-testing, it should be done every 5 years. And DEXA is something which is optional and which can be done every 2 to 5 years. Can we switch the regimen? Yes. Women who have premature ovarian insufficiency can be switched from OCPs to MHT and vice versa. And of course, we can always think of changing to Tibolone. A quick word about Tibolone. Now, Tibolone is a molecule which is not extensively used, unfortunately, but it has estrogenic action on the bone, vagina, vasomotor symptoms, and lipids. It has progesterogenic and anti-estrogenic action on the endometrium and the breast. and it has androgenic action on mood and libido. So it really works well in menopausal women who come to us with mood changes and reduced libido. We have to be very, very careful when we are prescribing it to women who are older with history of breast cancer or history of endometriosis or and fibroids. And of course, it can be added as an add-back therapy with GnRH analogs. The dose recommended is 2.5 milligrams single daily dose. 1.25 is equally effective. Adverse effects have to be watched very, very carefully, but please note that it should not be started within 1 year of menopause because it may cause irregular vaginal bleeding and creates a lot of confusion. There are certain contraindications that we have to keep in mind. If a woman has undiagnosed genital bleeding, women over the age of 60, and women who have known or past suspected breast cancer and or even suspected estrogen-dependent malignant tumors, we should think twice before prescribing tibolone. And of course, women with thromboembolism or history of DVT this should be avoided. SERMs, especially raloxifene, was in vogue for some time. It has a good action on the bone and lipid metabolism. It has antagonist effect on the uterine endometrium and breast tissue. So we did use it quite frequently in women for postmenopausal osteoporosis. Now, this is a molecule which somehow is not being used very, very commonly, but please note that it does not relieve other menopausal symptoms. Some important tips, and this is courtesy Indian Menopause Society. So women who have premature ovarian insufficiency, cyclic sequential estrogen progesterone therapy till the natural age of menopause. So the woman has to be counseled that she has to take this therapy for 10, 15, or even 20 years, depending on when the diagnosis of POI is made. Women who have sexual dysfunction, tibolone works wonders. Women who have sexual dysfunction secondary to urogenital atrophy, vaginal estriol cream works wonderfully well in these women. And for urogenital symptoms, I'm not going to talk about it. Maninder will be discussing it in details. What is new in therapy? So this is something which we all should be waiting for, a combination of estrogen and bazedoxifene, something called TSEC. And this is a molecule which should mimic something which is very, very ideal because it is going to relieve all the menopausal symptoms. It does not increase the risk of thromboembolism. And of course, it also works very well in the bones. And ospemifene is something which can be considered for women who have genitourinary symptom. So this is what the Indian Menopause Society recommends. Women who with less than 50 years of age, the benefits of MHT far outweigh the risks, so MHT should be offered. Between 50 and 60, the benefits of MHT outweigh the risk, then offer it to her, but not beyond the age of 60. Of course, women who are 70 and beyond, we will not even consider MHT in their prescription. Of course, the only exception probably is the local vaginal cream. So these are two important take-home messages for all of us. So menopausal hormone therapy should be used at the lowest possible dose for the shortest duration of time to reach the treatment goal. And MHT should not be offered to women who are unlikely to have a proper follow-up. So once again, thank you very much, Team Amogs, for asking me to join here. Thank you.
Thank you, Parag sir, for your comprehensive talk. I request chairpersons to give the inputs. Dr.
This has been very nice, elaborate, wonderful talk by Parag sir. He has given full justice to his subject. He has covered very nicely the consequences of estrogen deficiency, various terms used, wide range of products, estrogen, progesterone, intrauterine devices, various concepts, benefits, important points, various problems involved in the treatment, various contraindications, various drugs, information about tibolone and raloxifene, which is not known to all of us. This was very informative. And when to use, when not to use, all this information was very, very informative from your talk, sir. That was a very wonderful talk. Thank you, sir.
Thank you, sir.
Thank you, Dr. Parag sir and Dr. Sujit sir. Over to Dr. Suyoga for next session.
There is one question for Dr. Parag sir in chat box. So, one viewer is asking if the MST is absolutely contraindicated and the patient is suffering from severe menopausal symptoms. So, is there any alternative therapy available for such?
There are alternative therapies available. Of course, lifestyle modification comes first, and I'm sure Maninder will touch upon it also. And there are isoflavones which are available. So these are plant-based estrogen which have weak estrogenic activity, and they do work in some women.
Thank you very much.
Yeah.
Thanks.
Dr. Parag, you have covered it so nicely, but wonderful, each and every.
Thank you, Maninderji.
And thank you. The only thing is just one day back, only international webinar was there. And what are the new non-pharmacological treatments for hot flushes? So that is where we cannot give the hormones. So a new drug which has been approved by US FDA is Zolitant. So that has come up for the treatment, though it's not available. So it's just a theoretical like you are doing, and duloxetine is something we are again using for the hot flushes. Otherwise,
So I didn't touch upon that because they are the
these
SSRIs
drugs
and
are not
SNRIs.
available anyway.
Yeah.
But
So
we want to tell them, supposing if it becomes available, we should be fighting for more drugs with the pharma companies now. I think we have got a big, vast market, especially with Pfizer's being there. I think midlife is going to be very, very aggressive sort of a thing. So very happy with this chairperson, at least the one who is dancing, exercising, singing, balancing life everywhere. So he's the ideal one for the midlife. So Pfizer start working on this, the bringing in the new basket of drugs into the India. Because we are just having local vaginal creams and a couple of estrogens only.
I totally love the word aggression, madam.
Not to have aggression. Somewhere we have to be. Yeah.
I think Amrita ma'am wanted to add something.
Parag, it's a wonderful talk, Parag. Such a vast subject which can be discussed for years. You covered it in 30 minutes. That's really great. And
yes,
I feel that we can mention about the SNRIs and SSRIs for the alternative therapies. Of
Yes.
course, that is not in the MHT field, what you said. It's very correct.
I am in the webinar.
SNRI, and because they are available for us and we are prescribing, maybe they are the better options for the hot flushes or anything like that. But it is a wonderful lecture, I'll tell you, full of information, and it was very good.
Yeah, thank you, madam. The only one reference point is the Indian Menopause Society guidelines of 2020. If you read those, you can prepare any lecture on menopause.
Yeah, that is true.
Thank you, madam. Over to Suyoga.
Yeah, thank you, Madan sir. And after the excellent talk by respected Parag sir, we move on to the third session where we have respected Dr. Maninder Ahuja madam, a warm, friendly person, a senior faculty and a founder president of Society of Midlife Management to talk about genitourinary syndrome. And to chair this session, we have respected Dr. Kavita Banwal madam, who is the chairperson of Foxy Urogynecological Committee. And can we have a slide? Yeah. Dr. Kavita madam is the senior consultant and laparoscopic surgeon at Samarpan Hospital, Mangar. She is a recipient of Padma Bhushan.
I think you leave it because it wastes only time. So thank you so much. So I think let me introduce Maninder madam. Is visible, but you have mentioned. So I'm chairperson. So thank you so much. Good evening and namaskar to all the eminent faculties, including Chief Guest Dr. Kiran Kutkoti sir, Amuja madam, Pardesi sir, Bipin sir, and all the eminent speakers as well as chairpersons. So first of all, I would like to thank from the core of heart the conveners, Dr. Monica, Dr. Suyogya, Dr. Rashmi, Dr. Jaya, and Dr. Madan for giving me opportunity to participate in this wonderful program. So it's my honor to introduce Maninder Ahuja madam. So she is so active at this stage. So I think I should say her that she is a perfect example of winning the age. She is brilliant, always shining, smarter for her age, affectionate, wonderful, and compliant. She has created so many groups on diet, life, and exercise. At present, the director of Ahuja Healthcare Dental and Infertility Clinic, and she has devoted more than 45 years in serving the women from adolescence to menopause. Madam has been president of Indian Menopause Society a few years back, and she has served Foxy as vice president between 2013 and 14. She is an active member of many professional organizations like Ishar, Ispat, Narchi, and she is author and editor of many articles, including Journal of Midlife Health. She has also written two research articles, that is age of menopause and determinants to age of menopause, which change the infertility practices, as age of menopause in our country is 6 years earlier to other parts. And another article which has written that relationship of menopause to metabolic syndrome, and this study proved that incidence of metabolic syndrome is very high in our women. And madam has received many laurels and awards, and overall she is very smart. So I always love her dancing and her presentation. So with these words, I invite with great respect Maninder Madam, who will be presenting on genital urinary syndrome. So that has been, I think, the basic topic, which includes various menopausal symptoms and signs like dryness, burning, irritation, urinary symptoms, sexual dysfunction. So I think Maninder Madam will be the best person to deal these topics. So with these words, I invite her. And Madam, the dash is yours.
Thank you, Dr. Kavita, for the wonderful words which have made me younger again. And I'd say thank you to Dr. Kiran for inviting all these young Yuvas, Dr. Hara, Dr. Shaizas, Dr. Parag Biniwale, Dr. Vineet Mishra. We are all very young. So thank you very much for inviting us to young Yuvas. And of course, thanks to for all the conveners, Rashmi Keher, Kavita, and all those who are there. And that's a lots of effort made by them for arranging this conference. Dr. Monica, Dr. Suyoga, Dr. Rashmi Keher, and Dr. Jaya Koret Tusharkar. And if I don't thank my guest of honor, I think that is just going back into the times when we used to meet so often and we were so happy together. Ranjinder Singh Pardesi, Dr. Ambuja, and of course the Bipin Pandit. Has he left? Because already when he is singing, I am dancing there. So we are a quite good compatible duo we are. So my previous speakers, Dr. Shaijas and Dr. Parag Biniwale, who have done so wonderful that it will be a challenge for me to stand up to their standards now, because my type is a little off repeated, but still the story which is never told by the women. That is why it's important. So let's start talking on that. So already like that has been introduced. I think my laptop is overloaded now. It's going to be very slow. Yeah, it's being shared now. Am I audible?
Yes, madam. Yeah, yes, visible. It's visible.
Yes, ma'am.
Oh my God, it's not moving. The slide is not moving. I'll have to do something somewhere. Go down. Escalate. Yeah, I can see now. No.
Yes, madam. It's visible.
No, this is visible, but this is not full screen. Now, when I was making it full screen, then I could not see. Yeah, now I can see. So why? It's another syndrome which is of very, very important to a woman after midlife. Genitourinary syndrome of menopause. How come? It was her unspoken problems also called, because most of the women, they don't talk about it. They will come with itching, with problems, and might be with sexual problems, but she won't talk about them until unless we ask them specifically. So they can enter your room hesitantly and tell if the cough, they leak, you'll know. or they will ask again to go to the toilet, and then husband, wife come and they say, we want to talk in privacy. So these are the problems which us women are still hesitant talking about. So it was called the vulvovaginal atrophy, but that term has a limitation because that is describing the appearance of the genital tissues, but not in reality the problems which are there. Urinary tract changes are not there, sexuality changes are not there. So that is why in the year 2014, International Society for the Study of Women's Sexual Health and the North American Menopause Societies agreed that we should change it into a genitourinary syndrome of menopause. Now, very important fact about this is that this is, of course, a chronic and progressive disease. So it involves the urinary tract, but a broad spectrum of symptoms, which we'll be discussing in details. But prevalence goes on increasing. Like hot flushes, they go on improving. After 6 months, they will be improved somewhere 1.5 year, but may not be beyond 5 years, very less, very few rare women after 10 years. But this is a progressive disease because this is the through the estrogen receptors that the hypoestrogenism is there. So that being the progressive work, so if it's a 65%, 1 year after menopause, it's going to be 84%. So that is very, very important that this is a progressive disease. And it has a negative effect on quality of life. And only 4% they seek the treatment. And 47% when asked, they will tell you, yes, of course, they are suffering. That is why we called it the suffering in silence. And 50% were unaware that the management is available. They think they get anything lubricant which is available at home. They can apply any oil and they will be okay. So that is the ignorance also about the disease. And we doctors are still not talking about it. What about the male partners? Are they being affected? Yes, they also being affected. 52 to 78% of the women as compared to 58 to 60% of the women. Because if the women cannot have the sexual intercourse, on whom it's going to be effect? Intimacy problem, libido problem, because of the sexual pain are going to affect males also. So don't think that this syndrome is important for women also. It is as important for the males also. So that is important. And what will be the vaginal symptoms? That be vaginal dryness is there. Now, why that is there? I'll be just looking into following slides. Irritation, leukorrhea, thinning, vaginal pelvic pain, pressure, and vaginal prolapse can be there because of the weak collagen tissue. So dysuria, urinary problem, dysuria, urgency, Chigo's frequency is there, recurrent UTI infection because of the secondary infections of thin epithelium, and urethral prolapse, ischemia, vesical trigon will be there. So what is happening? This thinning of the vagina will lead on to the ulceration, dyspareunia, because of the decreased lubrication. There can be postcoital bleeding also because of the infection. There can be trichomonas infection, which can cause again postmenopausal bleeding. They might present as a postmenopausal bleeding. Decreased arousal, orgasm is there. Naturally, secondary to there will be decreased desire. But because of the low levels of estrogens and testosterone, also the decreased desire can be there. So loss of libido, arousal, and that is there. So now the main important thing is why these are all three symptoms? Because they have the same origin from the same origin is there in the fetal area. So that is why they have same embryological origin. That is why the symptoms are there in the three, because the same estrogen receptors are present in three parts: trigon of the bladder, lower part of the urethra, lower part of the vagina, and all these are they causing the symptom. What other condition where the same symptoms can occur wherever the hypoestrogenism is there? So that can be because of the premature ovarian failure, hypothalamic amenorrhea because of any reason, hyperprolactinemia, gonadotropin releasing hormone agonists, and aromatase inhibitors may cause vulvovaginal or urinary tract symptoms. Chemotherapy, very, very important for the cancer survivors. Please don't forget them, because I'm thinking of making an association along with the oncosurgeon so that they can refer these women to us and we can give them a better life. So that is what during these days I was planning to do. So chemotherapy, radiation, surgical removal of ovaries, they can all precipitate the symptoms, cigarette smoking. So this sexual dysfunction is a very, very important part of life. So why it's happening? Before premenopause, vagina is a stratified squamous epithelium with predominance of superficial intermediate cells and very few basal cells. Now, these superficial cells, they are full of glycogen. And that glycogen, under the effect of lactobacilli, is converted into lactic acid. Now, that reduces the pH 2.8 to 4. That prevents the pathological bacteria to grow. But when that pH is raised, so pathological bacteria also grow. So this hypoestrogenism, because the estrogen is having effect on the vascular, on the epithelium, on the collagen tissue, everywhere in the fat also. So anatomical, physiological changes are there. So the vascular flow is also decreased. Epithelial cytology, I have already talked about how it is changed. So secretions are also decreased. Delayed lubrication is there. Friability of the vaginal is there. You touch it and it just like breaks up. So vaginal dryness is there. So this is what is happening. That there is rugosities are lost. There is a shortening of the vagina and there is thinning of the vaginal wall is there. So this is how the epithelium is reduced. And what is that going to reduce? So lactobacilli are less, pH is increased, and increase is for bacterial vaginosis, transmitted infection, UTIs, and everything is there. So this is how you are looking at the vagina, and this is how you will find, and even the mons pubis is atrophied, labia majora, minora is shrunken, but you must look at the clitoris also, because the clitoral hood is also gone. So its whole system is exposed now to the trauma from outside. So what is that going to lead to? That vaginal changes, which I have talked about, are going to lead to dyspareunia, hypoactive sexual desire disorders, hypoestrogen, delayed orgasm, urinary incontinence frequency, and other urinary problem, urgency, stress incontinency, and postcoital bleeding, because of all these changes which are occurring in this thing. One very important thing is, which is occurring, of course, all the hormones. Estrogen becomes the predominant hormone, estradiol is left. But testosterone is also coming down. Now, testosterone is produced both by the ovaries, by the adrenals. And the both sources, adrenal because of the aging, and ovaries because of the hypoestrogenism. They are producing less of testosterone. And it has a lots of effect, not only through the androgen receptors, which are present in the labia, in the vagina, bladder, everywhere, but also through direct effect on the cellular, because it's a vast area which has to be studied, but they are doing lots of studies and they find that the testosterones are important and sometimes they are needed in these cases. So let's see her unspoken problem. If they are going to have impact on quality of life, and GSM, if untreated, can become aggravated, and there is a negative effect on patient's confidence, sexual health, and if the patient wants it, then only we should treat it if the patient is distressed. That is another slide will become. But when you are diagnosing it, just don't diagnose it on the symptoms only. Look at her vagina or vulva. Please get up from your chair, examine her, and then only examine, give the treatment, because there can be any of these associated conditions which may cause the same symptoms of irritation, pain, vulvodynia, vaginismus, psoriasis, some ulceration, unhealed ulcer, and cancers can also be there. So always examine her. And other medical conditions can be there, like the diabetes can be there, and then detergent, soaps, douches, over-the-counter topical products, even lubricants, tightly fitting clothes, panty liners, non-healing ulcers. So I've already said, look at the clitoris hood also. So we have to examine all. But if the patient is distressed, we have to give the treatment. But if they are happy, it's okay. Then you don't have to give them the treatment. And sometimes the partner may not be there. She's keeping the good vaginal health, so the infections are not there. Then she won't need the treatment perhaps until unless she is symptomatic. So just don't give because she had some. And what are the tests required? Normally, no tests are required. But pH testing can be the simple litmus paper which you can get. You can put it in the vagina, look in the changes. If the pH is more than 5 years, especially in some cases like premature ovarian insufficiency, when you don't know whether it is because of the hypoestrogenism or because of some other infections also. So if there is no absence, there's no semen or infection or blood, then pH of more than 5 is going to suggest hypoestrogenism. Another test which we are not doing, but which is written there in the books is the Rakoff staining with your cell count, superficial, intermediate, and parabasal cells. So normally superficial cells are more, but if the parabasal cells are more, that means the thinning of the vagina has occurred. So that patient should be treated. Yeah, very important part is examining these patients. Sometimes these patients are so tender, friable, you cannot examine. So even if you have to take the samples, so that should be taken with a swab stick only. You can show them the vagina. And the other thing can be done, we can apply the xylocaine pad, the jelly, or we can do it under anesthesia. But now my normal practice is I put them on estrogen cream locally. And once some healing has occurred, then we can examine again for infection and per speculum examination, everything. So for examination, like I said, you can use sometimes the lubricants and everything. But if it's very painful, please do this thing. Give her some local treatment for a week or so and call her again. So other non-hormonal treatments which are available there. So they say all the guidelines say that if the first line of therapy should be lubricant and moisturizer. Now, what is the difference between lubricants and moisturizers? Lubricants are just for penetrative sex or when you are examining patients, so that they are going to lubricate it. But moisturizers, if used, can be regularly, can increase the epithelial thickness, pH, everything can be. Then local dehydroepicenteral DHEA insert or spamifene can also be given, but we'll come to that therapy later on. Can we give oral estrogen therapy? Because that is very question. If the patient is having hot flushes and night sweats, for which we are going to give her, or the risk of osteoporosis is there. And those cases, when indicated, we can give oral estrogens, but normally they don't help. And we might have to add in them later on the vaginal creams or the vaginal treatment, whatever is available, we have to give. So lubricants, they don't change the actually the epithelial function is there. But the only thing is that they can facilitate sex. And if the sex is facilitated, then if you keep on doing the regular sex also, that will also keep your vagina healthy. And they say that the epithelial is also built up and pH is also better. So that way that can help us, and that keeps the couple satisfied also. So different these lubricants are available in the market, and they can be used anyway. And we were using KY jelly was the one which was used. Then there comes the role of vaginal moisturizer. This is the cream which I've been using, but this can treat the GSM. So that is why they say the first line of treatment should be either the lubricants or the moisturizers. So they can maintain the acidic pH also, reverse the histological changes of atrophy also. That is. Now we come to the hormonal treatment. Now, hormonal treatment is available now in different formulations and different forms. In India, though, we have just now available the tablets and the cream. The two cream available are the one is the Evolon and the other is the Primadine. So how to apply them? That you take 0.5 gram. Normally we advise, they guidelines say they 0.5 to 2 gram, but actually if you take that applicator, so half of that you apply daily for 2 weeks, so that is sufficient. And then you can change it to weekly. And the 17 beta estradiol vaginal cream is 0.1 milligram per gram is there. Then vaginal rings are there, 17 estradiol and estradiol acetate, which give you 7.5 microgram, and Temring 5 to 10 microgram per day. So the dose for everything is start using daily, and then you can use on alternate days also. But these are advised for 90 days. They can be kept for 90 days. So that is the advantage. They are not available as because our women and men are still not that worried about their sexual functions, which they are in reality, but they're not talking about it. The things are not coming out of this cupboard. So these both things, they can be inserted for 90 days. Then we have the vaginal tablet inserts, which are 10 microgram per day, one tablet for 2 weeks, and then twice weekly, same way they can get. Then Prestron is DHEA, which is available. And that can be an ospamifene is 60 milligram. Oral tablet is available, which can relieve the the painful orgasm which is there. So that can be reduced in the form of local. Ospamifene is the oral tablet. So estrogens, they are going to normalize pH levels, restoration of healthy lactobacilli-based flora, and decrease the frequency of recurrent urinary tract. Yeah, I forgot in investigations, if the patient is having frequency and urinary problems, you should get the routine urine tested. And most of the time, we might find it's there is no culture, but still get it tested because secondary urinary infection can be there. If it's not there, and after, despite the treatment, the symptoms persist, then you have to go for other testing, which Dr. Vineet Mishra and Dr. Hara Patnaik are there. So I was so happy to find them there that I don't have to talk about those things now. Vaginal rings, I've already talked about.
Madam, I'll interrupt, but you are the best. You should be talking, madam. I have been just seeing you. You know, please continue. Yeah.
Okay, thank you. Yeah, so if the urinary symptoms persist, then I'll see later on because I have removed those slides later on, no? And it was anyway becoming a long. So response when it is seen. It is seen within, actually they say 4 weeks or 6 weeks, but it comes earlier. Practically, it comes earlier within 2 weeks. 1 week, the patient will start feeling better. She won't be that much distressed as she will be this, because having that itching all the time and your hands are there, it's not a good feeling. And sometimes because of that itching, you can cause abrasion and everything. So you have to be told, tell them that they should be just pressing, or they can have the even Xylocaine presses also, but don't rub it. That is very important. If they rub it, then it goes on increasing and increasing. So that is very important. Endometrial impact, surveillance, that is very important, because Parag said with oral hormone therapy, always do the survey. That is very important. Follow up after 1 month, after 3 months, then 6 months. That is it. What about this thing? Now, these drugs are acting locally only. So they are not being absorbed from there. So then there is no need, at least for 1 year, because the studies are there just for 1 year. After that, should you be doing? I advise, do that. Because our women, sometimes they used to take more than the required doses because they feel so happy. So they say perhaps if they can use it twice daily, they will be much better earlier. So in those cases, secondly, where the endometrial surveillance is required is obese diabetic women. And when you are using CE cream, because that gets absorbed more than the other creams there. Added progesterone, not needed at all, because it's not being absorbed, so it's not having uterine effect. But again, like I said, endometrial surveillance may be most appropriate option, and maybe progestational agent can be considered when the patients are obese and diabetic. And if it is a uterine bleeding, it should be investigated. That is one thing. It should always be investigated. So most of the times it turns out to be benign only, but it should be investigated. Now, this is very important. This is the intracrinology. There is no systemic effects of these drugs like DHEA. They just locally act. They are the inactive hormones which enter the nucleus and they get activated. They have effect on the cells only. And then as inactivated products, they are secreted. So this is called the intracrinology of these drugs. And then become the SERM, which is the ospamifene. And you know the SERMs can have a estrogenic effect, progesterogenic effect, or the androgenic effect, whatever it is. Aspamifene had been tried for 52 weeks and can be given, improve the maturation and can cause improve the vaginal severity of self-identified or most like dyspareunia that will be improved as compared to the placebo, because there is not any drug available which is going to be effective in 100% of the patients. So you always have to counsel patients that you might have to try different drugs. Even in case of lubricants and moisturizers, they will have to try the different drugs. So as about the breast cancer comes the same. So FDA does not recommend its use in women at risk for breast cancer or the breast survivors, breast cancer survivors. What we should be doing, that I have put up a few slides there. And long-term effects on bone health are not known. You can say that this is going to improve your bone health. Risk of stroke is there, blood clots is there, cancer and the lining of the uterus, because it's being taken orally. So that is why all these effects can be there. So here we have to do the surveillance of these patients, not otherwise our other creams which are. Testosterone, as I have talked, there is lots of work going on in the animal studies and in the women also. And they're studying different pathways that is beyond the scope of this talk. But sometime, somewhere, I'll take that talk on the role of testosterone. So, but we can titrate the doses, whichever is available for the males, and then we can give them. We have now sprays available of the testosterone where needed libido is and the other drugs are not having effect, then we can use these drugs. Isoflavones, they have been tried, very small studies. So they found they have been efficacious, but still longer studies are needed before we can say that it is safe. I tell you, when you are listening to the international speakers, they never give you that you can use it like this. The studies don't allow us to use, they allow us to use like this time only. So when you are prescribing, please be careful about the counseling of the patient about these things, because once they get a cancer or anything, then they will blame you and they'll go to the other doctor and they'll come back. You said there is nothing going to be nothing, but this has happened. So that is very, very important. Bioidentical hormones, they are not being approved by any international society because there is not enough evidence, but lots of marketing is being as on-counter drugs by them. Now I come to the important topic of cancer survivors. Now we have given them a long life to these cancer survivors. What about their quality of life? That should also be improved. So that is very important. So most of these patients, cancer survivors, they have hypoestrogenism and they have most of them have vaginal symptoms. So what to do with them? Because hot flashes will be there, that I'll be taking a little few slides only. But about vaginal symptoms, that is very important in these patients. Perhaps lubricants are also. So in 65% of the patients, they have found in meta-analysis that the patients of breast or colorectal cancer, they had the sexual dysfunction. And sexual dysfunction can arise from other factors also, like biological menopausal surgery or psychological. They are depressed, they are anxious, body image is changed, interpersonal relationship problems are there, communications issues are there, social culture, religion, culture. They say cancer survivor going for sexual activity, perhaps still in the Indian scenario may not be accepted, but they need the closeness with their partner. So a holistic approach, including partners, must be best suited to address these issues. Local testosterone and aspamifene can be given, lubricants can be tried, and moisturizer, they can all be tried in these cases. Now, I'll tell you some conditions where we can use the local estrogen creams also. So these are the conditions where the cancer survivors, they have the vasomotor symptom or sexual dysfunction or vaginal problem. So what the therapies like, there are lots of things you will get on the net. So vaginal carbon dioxide laser, lubricants and moisturizers, they can have a possible effect. What about these lasers which we are using? So they have unlikely, but the people are doing studies And I tell you, the both way the results are coming. Some studies are saying they are useful, and some studies are saying not. But you are giving a heat, applying heat to the local area, that also becomes sometimes very soothing. Other thing which is likely is there, which is being popular in these patients, is the cognitive behavioral therapy. I think we should be taking more of the help of cognitive behavior therapy people now, and bringing them also forward for helping us in these situations now. So these are the cancers where lung, thyroid cancer, head and neck, gastric, pancreatic, malignant melanoma, bladder cancer. In all these cases, we can prescribe MHT. And if we can prescribe MHT orally, then we can give them the local creams also. So that is very important, non-prevalent. Now, what about these cancers which are female cancer? So breast cancer, if it's a hormone positive cancer, estrogen, estrogen receptor positive or triple positive, then we cannot, hormone positive we cannot give. If triple negative breast cancer then we can consider them. And other cancer, because I have a high grade, ovarian cancers are there. So if they are high grade, this is the paradox. If they are high grade serous lesion, endometrial, mucinous, clear cell, borderline germ cells, in all these you can give MHT. But avoid MHT where low grade serous, granulosa cells or sex cord stromal tumors are there. So that is only ovarian cancer variant. If the cervical cancer is there, then you can give MHT unless adenocarcinoma is there. And vulvovaginal cancers also, you can give MHT, but non-HPV related cancers, you cannot give if there are adenocarcinoma and Paget's related adenocarcinoma is there. So adenocarcinoma where you cannot give because they are hormone dependent cancer. Uterine cancer very early, in early cases, you can have a MHT if there is endometrioid cancer, serous or carcinosarcoma. And if it's a sarcoma, then they are estrogen sensitive, you cannot give them. No data on MHT post-diagnosis. Leiomyosarcoma, high-grade endometrial stoma, sarcoma, and avoid MHT in low-grade endometrial sarcoma and adenocarcinoma. So this is what you have to remember. Now, after pelvic external beam radiotherapy or brachytherapy, they have strictly severe vaginal problems are there. Perhaps with the help of Xylocaine jellies, you can use dilated pelvic floor physiotherapy, but vaginal estrogens, where indicated, can be given in them because they are really suffering from vaginal dryness, itching, and everything is there. Now comes the role which I was reading when the cancers and the menopause hormone therapy, that we can sometimes in these patients try complementary and integrative treatments that are culturally appropriate and more accessible than the conventional therapy. Because what we have to give them is the comfortable life. So that is what I believe them. Now, when you have given them a long life, give them a comfortable life also. So CO2 lasers and radio frequency devices, yes, they are being used now and tried, and the studies are going up because they produce a heating effect of the tissues, and the tissues are getting, they say, the better pH is there, epithelial is there, even the collagen tissue is being built up, vascularity is increased. So 3 initial treatment, but they always need follow-up after 6 months. So always tell the cost of the patient, they can always be tried, and follow-up of the treatments is required. So if the proper counseling is done, I think these and YEG laser, carbon dioxide laser, and radio frequency therapy team. Then what other therapies are being tried now is PRP. PRP is again also being tried in these cases. Stem cell therapy is also therapy. So we have a bigger basket of these drugs now. So we have 3 problems, but we have solutions also. But we have to diagnose them properly. Don't let the women suffer in silence. So bring out these issues out of the cupboards and please treat them. Thank you very much.
Excellent talk, madam.
I finished in time.
Yes,
Yes.
Yeah. I think it
Excellent
was
talk on
one.
the unspoken problems of
Thank
menopause. Over to you, Kavita madam, for your expert.
Yeah, yes, madam. It was wonderful presentation on vulvovaginal atrophy, which is now named as genitourinary syndrome of menopause by American Society. So you have covered, I think, almost all the topics, including cancer patients. You have described all the details about genitourinary sexual symptoms and their causes, and how the examination should be carried out, how the investigation required, and what should be the proper treatment. So first of all, we have to give local vaginal gel, moisturizers. If it doesn't improve, then only we can go for ERT along with the endometrial surveillance. So should be done regularly. And you have also mentioned many newer things like DHEA, selective estrogen receptor modulators, which should be given at least for 52 weeks to see the results. So I think everything has been well covered. Isoflavones, you have also flavonoids have been mentioned by you. And you have also mentioned nicely any details. I think till now I have not listened to any person talking about the cancer survivor patients. So you have mentioned so well that how can we improve their lives by giving many drugs, including local progesterone, osmifene, and yeah, you have also mentioned the role of laser and PRP that can be tried in some cases, and it will cause remodeling of the vaginal tissues and vulvar ear, and it will improve the symptoms of the problem, all the problems. So thank you so much, and it was very nice, elaborate discussion. So I think nobody here has listened to such elaborate way, especially a cancer survivor patient. We have not listened to anybody talking about that. So thank you so much, madam, for your nice presentation, and I congratulate you for the same.
Thank you. Thank you.
And
it was
thank you,
nice
society
being with
conveners.
Amogs. Yeah.
Yeah. Thank you, madam.
Thank you, madam. Over to
Namaste,
you,
Hara
Monica.
sir. Yes, madam.
Yes, ma'am. Thank you, ma'am. Thank you, Maninder ma'am, for an elaborate talk. We now move forward with our next academic session. Our chairperson for the session is Dr. Suman Sinha ma'am. Can we have her CV, please? Madam is currently the chairperson of Foxy Vaginal Surgery Committee. She has been the ex-chief of medical services and HOD at the CCL Hospital too. She has been the past president of the Ranchi OBGY Society, and she has held various positions in different organizations and has been at the helm of many. She has many awards to her credit. We welcome you, ma'am, and I would like you to introduce Hara Patnaik sir for his talk on POP quantification.
Thank you, Dr. Monica. Am I audible?
Yes, ma'am.
Yes, ma'am.
Okay, thank you. So a very good evening to one and all. At the very outset, I would like to thank all the conveners, Dr. Monica Amranand, Dr. Rasmi Kahar, Dr. Suyogya Panath, Dr. Jaya Kore, and Dr. Madan Kamble. But before that, I would like to pay my gratitude to our chief guest, Dr. Kiran Kurkurte sir, Dr. Rajendra Singh Pardesi sir, Dr. Bipin Pandit sir, and Ambuja madam. So I recognize the, efforts you all have taken, all the conveners, in making it a very power-packed program. So you have all the stalwarts here, and we are listening to such good talks. So as Kavita was telling, we have not heard in detail the presentation on this menopausal syndrome, what Dr. Maninder Ahuja has told to us. So without much ado, I take the advantage to introduce to all of you the next speaker. So it's really a delightful opportunity to have the honor to introduce to the gathering a very good friend of mine, a well-known figure of Foxy, a mentor to many of the societies like the Society of Vaginal Surgeons of India, IMS, Vaginal Surgery Committee, and many more such organizations. Sir is very creative, focused, and empathetic. He is also proactive and has tremendous energy. He is none other than Dr. Hara Prasad Patnaik, sir. So can I have sir CV?
Namaskar, Suman madam.
Sir,
I think
Sir,
think
he
you,
doesn't need an introduction, I
I
think.
think
So we
you
can
can put
straight away
the,
go to
yes,
the talk. Sir
yes,
is going to talk on a very important topic, that is positive quantification. And we all know how difficult it is. And I'm sure he's going to make it very easy learning process. So over to you, sir, and can you start your
thank you.
slides?
Thank you, Dr. Suman, for your nice and kind words. And I pay my regards to all the seniors present over here. I was listening to all earlier presentation of Parag, host disabled participant screen sharing. Please allow me to share my screen.
Yes, sir.
इसे लिखा है कि host disabled participant screen sharing. I think the host has to allow my screen sharing.
Bhavna, can you please allow sir to share his screen?
When I heard this webinar from Dr. Rasmi, I was really very happy and thrilled that it is really a very compact and academic program. And listening to Parag was a really, and Dr. Maninder. It was so nice, and I was really, they were covering very nicely, and it was really a message to be taken, and it's for the future reference and everything. Anyway, I think, yes, I think I can.
It's a great honor to have you with us today.
Thank you, madam. Let me see.
Farah, nothing is uploaded there. Yeah,
Farah,
now
open your
we can see.
presentation and then.
Now we can see.
I have to stop it again.
No.
No, it's okay. We can see
Open your
them.
presentation and then
Open
share.
them.
I have opened
Sir,
my
you just
presentation.
open the presentation and you close all the rest other tabs.
Yes, that is what I am going to do. This is my presentation.
Yeah, we can see. We can see. Yes. Just make it full screen.
Is it full screen now?
Not yet, sir.
Not yet.
Yeah.
The same problem continues.
We can see it nicely. Yeah. Okay.
I have to do it
So there is
again.
a button on the right hand corner of your screen.
Right?
Your right hand corner, slide 2.
I am seeing that.
Yeah, now you have opened it. Now your presentation, sir. Open it. We can see. Yeah. And
Can you see now?
Yes, sir, it is seen. It is seen. Yes.
Yeah.
Are we
There.
full screen?
Yes. Yes.
Okay. Thank you. By blessings of Lord Jagannath, I am able to meet you all. And it's really very nice to see you all stalwarts present over here. And today I'll be again speaking something about POP-Q classification and management. See, pelvic organ prolapse quantification, that is what POP-Q means. So, why this POP-Q classification has come and why we should follow it, this is the main area of presentation. Well, prolapse of pelvic organ is an entity we know from time immemorial. And second thing, it has negligible mortality. People don't normally die of this, but morbidity is many because we have everything starting from genital syndrome, decubitus ulcer, infection, vaginal dryness, and so on and so forth. See, it is mostly seen in the elderly. That is why a topic in the menopausal medicine. And but there is a distinct entity in a nulliparous even in the reproductive period. So, and one more important thing is the iatrogenic is the cause of post-surgical, which we call as wall prolapse. can be done by we surgeons because of a ill-chosen or ill-done operation. That is a separate entity. See, pathogenesis is least understood or ill understood, why it happens, how pelvic organs are supported, why it falls, and all these things. So you have to understand the pelvic anatomy, which is surrounded by steel by means, and you see in the upper part, the answer is suspension. The middle part, the answer is attachment, and fusion in the lower part is the rational concept. That is why the pelvic organ remains in position. So classification and staging an enigma and controversy, because from time immemorial we are classifying how we are going to stage. So what are the factors which really responsible, that we all know that there are certain activating factor and some aggravating factor. If you have an inherent weakness in the support of uterus, naturally following pregnancy and childbirth, following menopause and post-menopause, iatrogenic means post-surgical. So these are the activating factors which will show in form of POP. So the aggravating factor like chronic cough, raised intra-abdominal pressure, debility and asthenia, so on and so forth. So, you know, there are the supports of uterus at the pelvic organ. We can say there are ligamentary support, there are fascial support, there are muscle supports. We know the ligaments, the uterosacral ligament, transverse cervical ligament, and other broad ligament, other thing, and the fascia and the muscle, mainly the levator ani and other superficial muscle. See, biochemical hormone is the fourth dimension. Estrogen plays a pivotal role, and following estrogen depletion, there can occur pelvic organ prolapse. So, the level of support which as claimed by De Lacency is a three-tier system. The upper tier, which I was telling, is the suspension. Middle is the attachment, and lower the fusion, what I was going to tell you. See, how do you classify prolapse? So there is the classification was earlier done earlier from the time immemorial. What is the older system? You see the anatomic side, you see what are the structure which is coming out, and you stage them. You stage them as mild, moderate, or severe. Mild degree of prolapse, severe degree, moderate degree of prolapse, mild degree inside the introitus, inside the vagina, moderate coming out of vagina, and severe, what do you tell as stage 4 of this. So, the strength is that it is very easy to define. Anybody, any general gynecology, general practitioner can tell mild, moderate, severe, because he is seeing it. But it has got weakness is that it is only subjective. This varies from person to person. If I say that this is the label, the degree, I cannot quantify. Second thing is it lacks the anatomic defect and lacks, I told you, lacks the quantification. So, what are the sites of prolapse? One will be anterior, will be urethrocoel or cystocele. Many times we join together telling at cysto-urethrocoel, that is the anterior one. The middle one is the uterovaginal prolapse. Describe the prolapse of the uterus, cervix, and upper vagina. The posterior part, the enterocele and rectocele. Upper 2/3 is enterocele, lower 1/3 is rectocele. See, anatomical classification according to vaginal wall, that is what I have told you. The anterior wall is cystocele and urethrocoel. The apical middle compartment is the enterocele, uterine, uterovaginal, and vaginal wall or the upper vagina. Posterior one is rectocele. So the older concept, let's come back to the old concept of Shaw versus Malpass. It was called first degree prolapse, second degree prolapse, third degree prolapse, fourth degree prolapse or posterior. The other says no fourth degree, first degree, second degree, third degree. Before that, mild, moderate, severe. Very simple and very easy to understand and very easy to practice. So the understandable apical and central defect is understandable, and again the site specification is lacking. The anatomical landmark Why do you tell that is a first degree, second degree, third degree? It is the ischial spine or the hymen is the anatomical landmark. Now that because we lack the concept of quantifying it, if I produce a paper, I want to say, I cannot explain Rasmi at what level my prolapse is, my patient's condition is. So if I quantify it, she can immediately assimilate and tell that, okay, he is telling that these are the levels at which it is there. So there are two systems today, Baden-Wacker halfway system. So it is relatively easy, they say, and many people in Maharashtra, they also use it today. And the other one is POPQ, prolapse, pelvic organ prolapse quantification system. A little bit of Baden-Wacker, user-friendly. Dr. Saravagi told me, Rajendra Saravagi told me that we still follow Baden-Wacker halfway system because user-friendly, easy to record. The maximizes the amount of detail that can be recorded in a brief space and lack of specific defect again. Again, lack of quantification. Here, there are 6 defined sites in the vagina: urethra, vesicle, anterior part, uterine cul-de-sac, the superior part, rectal and perineal, the posterior part. So, extent of prolapse from -0 up to -4. So, reference point will be 2 again, the ischial spine and the hymen. The perineum, it is graded difficulty as perineal tears. So, strength of the levator contraction has to be also assessed. So, -0 or -4, and you have to measure the strength. So, this is what in nutshell. So, you can see that this is the ischial spine, the reference point, and this is the vaginal cuff. Below it is, above it is the uterus, and halfway of hymen is this ischial spinal level is 0, halfway is +1, +2 below the hymen, and half past way to hymen is 3, and maximum descent is 4. So now that we come to POPQ classification, how it evolved, is there a need or not? What is the actual classification system? See, 3 societies, they joined hand. International Continence Society, ICS, American Urogynec Society, AUGS, and Society of Gynecologic Surgeon, SGS. They joined and they want, no, this malpass, this earlier classification is not efficient or sufficient to quantify. Let's make it more scientific and more rational to this. So the need was the need for quantification, and it should be specific, site specific, and there should be a objective assessment. You can know, and better communication and understandable. If I write it here, people across the globe in United States, they can understand, yes, this is POPQ so and so. Measurement is done in centimeter, and it is not arbitrary. It is an actual measurement. So why we want to quantify the prolapse? We want to compare the outcome of surgical repair before surgery and after surgery, and it will be always inter-individual reliability. What measurement I will do, the same measurement Dr. Suman will do in Ranchi, the same thing will be done by Rasmi over there. So the standards in written publication and scientific presentation. So earlier, malpass classification or SAW classification, mild, moderate, severe, stage 1, grade 2, 3, 4 was just a subjective thing. Now that this is exact measurement, why you will go. So it has got a strength, it has got a weakness. What is the strength? More scientific, and it can be reproducible. If I write it here, if I publish a paper, the other people all over the world, they will say, and it is reproducible. So the weakness is that it appears more complex, and many of us really leave that, say that is not necessary for my operation, for my management, it is not required. So let's forget POPQ. So whether it is easy to understand and difficult to practice, or difficult to understand or easy to practice, let's see. So the system is very simple. Here 1, 2, 3, 4 I will tell. There are reference points. two anterior wall, what do you say as AA and BA. Two posterior wall, I'll show the picture. AP and BP. Two apical, C is the cervix or the cuff, D is Douglas or pouch of Douglas. Measurement, proximal to hymen will be minus. 0 is hymen, above that -1, -2 and -3. Below that +2, distal to hymen. Three distinct measurement. What is that? GH and perineal body and total genital hiatus is GH. Perineal body is PB and TBL means total vaginal length. So there is a grid system of presentation which I will do. So measurement is done. I told you it will be done in centimeter. You have to take a scale. The scales are available now, not tape, straight. So their plastic or elastic tapes are available. So hymen is the fixed point of reference. Plane of hymen is defined as 0. Above is negative, below is positive. Now let's see. What is AA? Can you see? So if I show my cursor, this is the point AA. And the other one is BA. I will again say where is it situated, and apex is CD. You can see the cervix over here and D in the back, Douglas. Posterior is AP and BP. Now this is the genital hiatus. So GH and the perineal body over here, and total vaginal length from cervix down to introitus is total vaginal length. Now, you see, genital hiatus is GH, perineal body I have shown you, total vaginal length. These are the three measurements. These are the three measurements you have to actually do in a measuring tape or a measuring scale and write it down. GH is this centimeter, perineal body is this centimeter, and total vaginal length. What is point A? It is an anatomical defined point. Where is it? It is midline of anterior or posterior vaginal wall. Can I come back to the picture? It is 3 centimeter proximal to external urethral meatus or urethra or hymen. Can you see the picture again? You can see this is point A. So, where is it? It is 3 centimeter proximal to external urethral meatus. Now that you can go back. Anterior, P is posterior. So, defined points, midline anterior vaginal wall, 3 centimeter above external urethral meatus, AA, and midline posterior, 3 centimeter proximal to the hymen is BP, posterior. Can you see that? And now point B. Point A is a fixed point. Point A will not change, but point B will change. So it is dynamic or a variable point. It is the most distal position of any upper vaginal wall between the anterior or posterior fornix or cuff and A. It is the descent which will show where the point B lies. Again, the value is -3 centimeter in absence of prolapse. So let's see BA and BP. So point B is dynamic or it is variable. BA, this is the position. This is AA, which is fixed. BA, there will be descent. Most distal point of any part of the anterior or posterior vaginal wall from the vaginal cuff or the cervix to point A. So this is BA and BP. So if you draw a line diagram, AA will be somewhere here, then comes BA, C is the cervix, BP posterior, AP is here. So the measurement will be, this is plus and this is minus. Posterior will be minus and this is positive. What is the difference between point A and point B? Point A is a fixed point, 3 centimeter apart from hymen, anterior or posterior. So A or BA. B is the most descending part of the compartment anterior or posterior, right? So genital hiatus is the middle of external urethral meatus. It's the external urethral meatus where the urethral opening is you see in the vagina, introitus, and the posterior hymen. This is the distance is called genital hiatus. Cervix or the cuff is here. You can see in cervix. This is the most distal edge of the cervix or leading edge of the vaginal cuff. When you say, when hysterectomy scar is there, you can say Douglas or pouch of Douglas, the posterior fornix or the pouch of Douglas. It represents the label of uterosacral ligament attachment to the posterior cervix. If you have no cervix, there will be no point D or no Douglas pouch. So perineal body is the posterior margin of genital hiatus to the mid anal opening. Right? So this is the perineal body from the posterior margin of genital hiatus to the mid anal opening. It is the anus opening and this is the perineal body measurement. Total vaginal length is the greatest depth of the vagina in centimeter. So C and D will remain in normal position, then only you will do the measurement, and the measurement is again done by a tape and the patient should not strain. So now you stage the pelvic organ prolapse according to POP.
That we can't hear you. There is some network issue, I think.
His connection is lost.
Will come soon.
Ma'am, it must be temporary network issue. Temporary.
Yeah. Hope so. Hope
Yeah,
so.
it will be temporary only.
Got it. Sir has come back.
Madam,
Yes, sir.
there is a network issue. I am joining. Are you able to hear me?
Yeah, we are.
Yes, sir.
So the thing is that I wanted to show the stages now. After you have quantified the point and the measured the distance, then only you will be able to speak in pop cube measurement that this is the distance and this is the position, right? And then only you will be able to quantify whenever you are writing a paper on pelvic organ prolapse. You will be able to say that this is my measurement and this is the position of the fibroid. And in all these cases, you should always.
Yes, sir.
It was almost
Parag,
over.
can you go back to last slide? We missed that, na? Last slide.
Yeah. You missed the last slide. Let me see. My God. Okay. Right. So now that if I will see that if I can show this slide. See, stage 0 is when there is no prolapse.
Yes.
Right? Are you able to understand?
We can understand,
Yes,
but
sir. Yes.
visibility
Okay.
is not there.
Let me go back to
Last one.
एक minute. Why it happened?
I don't know.
As technology advances, this is a new one, which I have got it, and the old one was still better.
Can you read out from that place so that we can just
I
hear?
can read out.
Yeah, you
Yes,
just.
that was the last slide.
Yeah.
I am just trying to see if I can do it. Otherwise, I will read it out. That's all.
We have understood.
First stop sharing, then share again your screen.
And yes, I am doing that. Just a minute. I think that the last two slides were remaining, and yes, yes. Oh. Again, she has disabled.
Somebody will have to make co-host to sir, then only he can display. Dr. Monica, can you look into
Ma'am,
it?
he is the co-host.
Acha, you are there ना? Okay.
My host has disabled.
ऐसा क्यों लिख रहा है?
The co-host. So you can read out from your slide.
I think that I will do. Right.
Yes.
So the thing is that if I can say that it is a stage zero, stage zero is there is no prolapse. My God. So AA, BA, AP and BP are all in -3 position. Right? They will be in the normal position. AA and BA, AP and BP are all -3 above hymen. C and D between total vaginal length where TVL is less than 2 centimeter. Do you understand? So that there is no prolapse, we stay at stage 0. And stage 1, the most distal portion will be more than 1 centimeter above the level of hymen. It has come down, and so that it is above the level of hymen, and you can say that this is stage 1. Stage 2 is less than 1 centimeter proximal or distal to the plane of hymen. Okay? And stage 3 is more than 1 centimeter below the plane of hymen. And stage 4 will be complete eversion, distal portion, and the least is tibial is -2. Right? And this is the thing which I wanted you to
Wanted to
learn.
see the grid actually.
Yes,
Yeah,
that is what I actually wanted to show you. And in all these cases, protrusion of the vaginal wall should be seen during staining. If the patient has to be, and traction will cause no further descent. These are the second thing. The position will be finalized. Even you pull it, the position will not change. And the subject, the patient will confirm the size of the prolapse. Right? And standing, straining and examination will do it. Hello?
Yes, sir, we can hear you.
And the grid actually I wanted to show you is a AA or BA or C, GH or PBA, TVL. This is what the grid suggests. So the physical examination of the technique will be position of the subject, type of vaginal specula you use, whether the patient will be straining or coughing, bladder should remain empty, or it does not really matter, but in all our examination, bladder should remain empty, and the method of quantitative measurement should be done. So the point and landmark of POPQ system of examination, I just wanted to show you. And the final word is standardization and uniformity of classification is necessary. Staging is important for appropriate surgical technique. It should be simple, user-friendly and reproducible. It is now that it is thing is that it is not that simple because people do not adapt it. It is not that user-friendly, but it is reproducible. It is more objective rather than subjective. It is estimate rather than guesstimate. With this, the surgical goal and things I will speak later. I am very sorry because I could not complete the last one because of this. Thank you very much.
Thank you very much, sir. We would like to have remarks from our chairperson, Dr. Suman Sinha, madam.
Yeah.
Thank you, Patnaik, sir.
Right.
Actually, in the beginning only, I told you that it's a very complex topic, and sir has tried to make it as easy as possible. So actually, we have to take it. We understand it that it's a specific system which is used to describe, to quantify, and to measure the supports of the uterine prolapse, measure the stages of uterine prolapse, rather you can say. And there are two systems, POPQ and the Waden-Walker scoring system. And sir is very right. We all are following Waden-Walker scoring system because it seems to be easier. And staging is so, we are so used to do the staging. We're looking at by our eyes and seeing the patient, we can say, oh, stage
Can
1.
you see it right now?
Yes, sir.
Yes, sir. Now it's...
Is it yours, sir?
Yeah.
Yeah, we can see it.
This is what I wanted to say as stage 0, stage 1, stage 2, and stage 3 and stage 4. Earlier Malpass classification or SAWS classification. So this is what I told you: physical examination technique, protrusion of the vaginal wall, and the traction should be there and it should not change, and the subject should confirm this, and this is the grid.
Yes.
This is the grid I wanted to show you. AA, BA, and C, measurement of GH, genital hiatus, perineal body and total vaginal length. AP and the BP and D or the Douglas has to be done. And the physical examination technique, I told the position of the subject, type of vaginal specula you use, it should be straining or coughing, bladder should be empty, and method of quantitative assessment has to be done. And this is one I wanted to say, point and landmark in POPQ classification. You see, measurement in centimeter, you say this is AA and this is BA, this is AP and this is BP, this is C or the cervix or the cuff, this is Douglas, the posterior one, and this is the genital hiatus and perineal body and TVL. If you have a picture like this, you can also write the measurement over there and you can send it across to any place you want. So an example of measurement using POPQ system will be like this, and it appears little complex. AA is -3, in normal BA is -3, C is -6, GA is 4.5 the measurement, perineal body is 1 centimeter, and total vaginal length is 8 centimeter, and AP is +2 position below the hymen, and BP is +5 below the hymen. And this, if I picturize and put it in my publication, there Dr. Rasmi can read it and say, oh, sir is telling this. So that is what she can understand. And that is what I say, that this is exactly the measurement has to be analyzed and can be known by the other person. So it is estimate, actual estimate, no guesswork, no guesstimate. So this is standardized and uniformity of the classification. So second thing is staging is important for appropriate surgical technique, and it is not that simple. We can still working on it, how we can make it simple in the Indian perspective, and it should be user friendly and reproducible. So it is more objective rather than subjective. So that's all I wanted to say. Sorry for the last minute problem, I think I am able to clear your doubt, and in some session we can show the surgical videos and we can discuss the surgical pattern. Thank you very much.
We can also take a quiz like that, so you can put 3 or 4 grids and then we can answer what it is.
Okay.
So
Yes.
the grid what you showed was a rectal prolapse, I think.
This one? This one?
Sir, ये rectocele है ना? Enterocele or rectocele?
Yeah, the posterior one.
Yeah,
You can
so
see that.
then it will be enterocele as well as the rectocele.
Yes.
So likewise, we can put some quiz.
You can put some quiz and show the grid, and you can say that this is POPQ classification, and this is the standard, and this is the one. You can assimilate. This is what we saw in Sawyer Malpass. This is what we see in Baden-Wacker, and this is what we see in POPQ. That can be another one which we can do. Thank you.
It's very important that when we examine the patient should, we have to take measurement twice. One is when you want to see the vaginal length, the TVL, then patient is not asked to strain. Okay. And after taking the total vaginal length, then we'll say patient to do either the Valsalva or she can strain as much as possible, and then the points will be taken.
Yes. Thank you.
This is also very important.
Thank you very much, sir.
Thank you very much.
Thank you so much.
Thank you, Suman ma'am, and thank you, Harapatnai sir, for an elaborate talk on the POQ classification. I'm sure it must have cleared almost all the doubts of the delegates too. I now request Dr. Sanjay Saharan madam to please take over the next session.
Thank you so much, Dr. Thank you, Dr.
There is a special mention that Dr. Sanjay Saharan, madam, she is a committee chairperson of Amogs Midlife Committee. We welcome you, ma'am, and we would like to you to proceed with this session.
Thank you so much, Dr. Rashmi. Thank you for having me here. And I would like to thank Dr. Kiran Kurtakoti, Dr. Parag, Dr. Bipin Pandit, Monica, and Suyoga, all of you. Thank you for having me here. So I have the pleasant task of introducing the chairperson for the next session on SUI. She is none other than my dear friend, Dr. Varsha Lade. She doesn't require much of introduction. She is the civil surgeon, Nandurbar, Maharashtra, director of Prayag Hospital, Nashik, past president of the Nashik OBGY Society, past zonal coordinator of Amogs, and also the past chairperson of the Ethics and Medical Legal Committee of Amogs. She's been the state coordinator of Amogs, joint secretary IMA. She's won a lot of awards, and prominent amongst them, Sri Shakti Award at the Jalgaon Viman Maharashtra Cha Puraskar, V for Sri Puraskar. She has been awarded the best paper at Amogs 2004. She is also the member of the Adolescent Committee of Foxy, being a member of the Planning Committee, Family Planning, and Breast Diseases Committee. So I welcome Dr. Varsha, and she will be introducing the speaker.
Yeah, thank you so much, Sandhya. And thank you everyone for making me part of this superb webinar. So it's my pleasure to welcome Dr. Vinit Mishra, sir, our very own Foxian from Ahmedabad. He is an obstetrician and gynecologist, as well as a medical professor and HOD of department with specialization in obstetric and gynecology in the Institute of Kidney Disease and Research Center, Ahmedabad. He is interested into endoscopy as well as IVF and infertility. So may I present to you Dr. Vinit Mishra, who will be talking on SUI as a very common complaint of every woman. And let us hear from him. Welcome, sir.
Varsha, I have been thrilled that I have been introduced by Varsha. And Varsha and Nita are very close friends. I would like to thank the entire team of Amogs, starting from Kiran to Rajendra to our Bipin sir, the present tense of Amogs, the young dynamic people, and would like to specially thank Madam Rashmi for pursuing and keep on writing. It has been an excellent opportunity to hear Parag, to hear Madam Maninder. I have been in Foxy because of two people. One is Dr. P.C. Mahapatra, and the other is Hara Patnaik. And the Urogynec committee started with me, and I was the first Urogynec committee chairperson for Foxy. That they convinced, both of them convinced the president and the committee that there has to be a Urogynec committee. And now it has been taken forward. Kavita is there. Rashmi is taking extreme degree of interest. And what I see is the future tense of Foxy and Amogs being here within the committee, and I am seeing their face. Madam Maninder, I was listening to you.
Yes.
You said that there are certain medications which are there in US, which have not come here, which would be effective if they are in India. Madam, share me an email. I know the owner of Corona, Mr. Mehta, and I will be able to convince him that these drugs have to be in India, and Nirav ji will not disappoint us. And your suggestion that all these medications, if they are here, will be able to manage our patients much better. So I had an opportunity. Kavita ji had okay. I need to share my screen.
You can share, sir. You are the co-host.
I am the co-host. Okay. So I have already the. Are you able to see my slides? No.
Not yet, sir.
No,
Not
sir.
yet. Oh. I am becoming the past tense of Foxy with all these new gadgetries coming in. The only person who can keep up with all these things is our Madam Maninder. You know, she's always updated. And even if I am able to do 5% of what she does now, I will be.
Thank you.
Wait a minute. I have to go to share screen. Share screen. Allow us to share the screen. That is what it is coming.
So you are the co-host. You will be able to share your screen, sir.
How do I do that, madam?
So the green button down.
So there is a green button on the bottom line.
Yeah.
Share.
Just click on that, sir. We will be able to see your screen.
You are sharing the
We can
screen.
see the screen, sir. We
I
can
can
see your
see the
screen.
share
You
screen, so
have to
he cannot
minimize
see it.
this, sir.
Now, can you see?
Yes, sir. Yes,
Yeah.
sir.
Yes,
Perfect,
sir.
perfect, sir.
Make it full screen.
So there is a button on the right hand side. Yes, sir.
Good, sir.
Perfect,
You have done
perfect,
it.
sir.
Done it, huh?
Yeah,
Yes,
done
Yes,
it.
sir.
See, I have been able to do it because Maninder gave Ashirwad sitting in Faridabad. Huh. So,
That's true, sir.
so see, I have changed from my regular Windows OS to Mac. So some of these videos may not work, but I will definitely, anybody who wants those videos or operative videos, just WhatsApp me or I will be sharing them. I'll give them my Google link. Incontinence, as everybody knows, that it has never jeopardized a woman's health, but it does play a havoc with the woman's ability to live and enjoy a life free of worry and wetness. All of you will agree. See, there is going to be an agony, a mental agony, and a physical agony if the woman leaks. So, etiopathogenesis is there is hypermobility, loss of suburethral support. That is how we put in a mid-urethral tape. Then there is intrinsic sphincter deficiency where we put in the retropubic tape or do bulking agents are put at the level of the bladder neck doing a cystoscopy to create a hammock under the bladder neck and urethra to form a support against which the damaged sphincteric unit could be co-opted, and to suspend the bladder neck to correct the hypermobility. There is a magnitude of SUI. We have stalwarts like we have Ambuja madam, we have Maninder madam, we have the other senior most people, Hara. They will say that if we are able to just ask one simple question, do you leak? Or is it bothersome first? Do you leak? We'll be aghast. One third of our patients would say yes. Is it bothersome? Many of them will say, and if you tell them okay, it is treatable, so most of them will come forward and tell you that if it is treatable, then they would like to go and get themselves treated. So there is pharmacology, there is physiotherapy, and then there is a last resort of surgical intervention. And there are diagnostics. All of them work. And believe me, there would be some of the clinics which are coming up would in future tense come up where they will only be dealing with pelvic floor, some amount of prolapse as Hara was describing the POPQ, and a leak which is happening. 30% of females after 5 years of hysterectomy will develop SUI. All of us would have come across a case where there is a prolapse and we have done hysterectomy, vaginal hysterectomy, and walled suspension. 1 week later, the patient comes back and says that you corrected one anomaly, and now I have developed that it leaks. I am leaking when I am coughing, or I have to run to the bathroom because there is little amount of what you call overactivity of the bladder. 30% of females after 60 will develop SUI, and 60% will develop SUI after 70 years. We are going to have huge number of our females who would be 70 and above. So, surgical management was we have to restore the active mechanism of continence, we have to restore the anatomic function of continence, and we have to restore the mucosal seal mechanism. So, what are the new options that are available? Colposuspension, that is laparoscopic colposuspension, open colposuspension, open birch colposuspension was the gold standard, and every procedure that was innovated or which came in was compared with the open birch colposuspension. Then came in laparoscopic colposuspension, younger generation, the future of our Foxy and of our country, where laparoscopy has been taken up in huge way by our fraternity. So there is going to be laparoscopic colposuspension. Only thing is you need a mentorship where you will assist at least 30 laparoscopic births and do 30 under supervision. That is the time you will perfect the skill or art of laparoscopic birch colposuspension. Pubovaginal sling, tension-free vaginal tape, transobturator tapes, and artificial urinary sphincter. These are some of the things which are there. Some or the other, this MEC is not taking up Kodak, and STEMI's procedure as well as, pubovaginal rectus sling. All these are small videos. If Rashmi would share the WhatsApp or in the group, I will put in these videos which people could watch them. Pubovaginal sling. Autologous tissue slings are since ages. Rectus facial sling. You know what is the thing which is happening? Anything which happens has to circle and come back. That is the philosophy of Prarabdha. So, Madam Maninder, this rectus facial vaginal sling, which was there in 1942 to 1946, rectus facial free graft wrap, 95. Then there was fascia lata or iliotibial tract slings, and vaginal wall slings, which were much before the prosthesis or the medical fabric slings which came in, which were polypropylene macroporous. And as all of us know, in the Western world, utility of mesh has become mess. So there are a lot of litigations which were coming up. But still in India, the mid-urethral sling using a macroporous polypropylene is still well accepted. The synthetic material which was there was monofilament polypropylene tape, which was TVT, tension-free vaginal tape, where Almstein in 1996 was the scientist or the gynecologist who or a urologist who basically devised this. Then came in multi-filamented polyester mesh, which was a failure. PTFA was also not much accepted. Silicon elastomer tapes, which was also not much accepted. Collagen injected woven polyester, which also did not become very popular. Indication is, where do we do a pubovaginal sling, where this prior failed incontinence operation, where you do a urodynamic and primary intrinsic sphincter deficiencies there, mid-urethral where the pressure is less than 20, any kind of SUI, pure type, 3 to 2 or 2 plus 3, cystocele is there, urethral diverticuli is there, hypospadias, epispadias, or even neurogenic incontinence is there, where one could use a pubovaginal sling, which could be used. The advantage, I will send across, Rashmi ji, I will send across these videos as after the seminar is over, so we can always share it in the group. Advantage of sling was it was less morbid, it was versatile with minimal complication, and there was objective evidence of improvement, better patient compliance, good tolerance. It was basically inexpensive and effective in about 85 to 90% cases. Two people from Sweden, Arnstein and Papa Petros, they published an article in 1995 which basically changed the entire management of female urinary incontinence. They published it in Scandinavian Journal of Urology and Nephrology. What was it? What is tension-free meaning? If you see, more than 200 surgeries have been evolved for treating the female incontinence. Many of them failed because majority of them were anchored. Either they were anchored in the posterior aspect of the symphysis pubis, or they were even anchored at the, what you call, the ischial tuberosity. They were anchored at many different places. Many of them failed. But when TVT came, the process which was evolved by Papa Petros and Arnstein, that worked because it was not anchored anywhere. It was left loose. That is why it is called tension-free. And lately, the fibrosis took place. There was macrocytes who came in, fibroblast came in, neoangiogenesis took place, and that tape became part and partial and was acting as pubourethral ligament. We have, this is the incontinence, these are the initial TVT which we did, and if you see, this is the pubic tubercle which you see on both the sides, half an inch above it, and half an inch horizontal incision. You just need to put in your 3 fingers, your middle finger, index finger, and ring finger. So middle finger or the middle finger remains in the center, index and the ring finger. That is where you put in this incision. See, madam, this used to be the initial tape which came up as TVT. So this was basically, you see, these 3 components were there. a stainless steel 10 millimeter diameter needle on which you will see that this tape was put in. There is a loader here and there is a long stainless steel rod which was put into the Foley's catheter and which was used as deflector. Now, mid-urethral incision was put in and this was dissected almost on the till the posterior aspect of the symphysis pubis. And then you see this loader loaded the needle and there was one loader and it loaded the needle. And then with the help of your left index finger, you put in the needle pointing towards the ipsilateral shoulder of the patient and gliding it on the posterior aspect of the symphysis pubis and coming out of the incision where you put in the stainless steel rod in the Foley's catheter and deflect it on the same side, meaning here you are seeing that you are putting in the needle on the right side of the patient. So this is deflected towards the right side so that the bladder neck and everything goes away from the path of this needle. Then you need to do cystoscopy. Believe me, friends, and my seniors, when me, Hara, and we went across and started demonstrating this, we got these tapes as free from J&J. And this tape that time was expensive, 30,000 rupees. We are talking about early 2000. But if this stainless steel needle was passing through the bladder and on cystoscopy on the screen, if shiny metallic material was passing through the bladder, there was almost asystole happening to the relative of the patient. Most of these patients were mother and mother-in-laws of the doctors of the local society where we went to demonstrate, because this was an expensive prosthesis. This was brought up. Similarly, on the other side, this thing is loaded. It is brought up. The most crucial part is, as all of you know, that a curved dissecting scissor is put between the urethra and the tape, the retropubic tape. If there is intrinsic sphincter deficiency, the entire tape is more towards the bladder neck. But if it is urethral hypermobility, then it is placed exactly at the level of mid-urethra. Then you just close the vaginal incision with, say, 10 or 20 Vicryl, and then cut the suprapubic mesh so that it falls below the skin and a simple stitch is taken. Foley's catheter is kept. After the effect of anesthesia goes away, the Foley's catheter is removed. It is done under short GA. So maybe after 2 hours to 4 hours, the patient starts walking, you remove the catheter, and patient goes to the loo and tries to assess. And if she says that she stops leaking, oh, she is delighted and she is on the ninth cloud. But what happened, intraoperative complication, bladder injury was almost 19% when previous surgeries were done. Bladder was not properly drained and little amount of medial retraction of the needle was done. That time bladder injury, but nothing to be afraid of. You remove the needle, you again pass it little laterally, put in the Foley's catheter and leave it for about 5 to 6 days or 7 days. There were urethral injuries, vascular injuries, and bowel injuries happened because if there was previous surgeries which were done and bowel was there stuck in the pelvis, then even bowel injuries are being noted in the literature. These are post-operative complications. De novo urge incontinence, which was a terminology which was initially used, meaning that after doing the tape, 20% of these females would develop urge incontinence. Later, it was found out with intensive aerodynamic study done pre-operative and post-operative that there was a component of urge incontinence which was a small in number, majority was SUI, which was missed, or it was more bothersome SUI was there. So what you do is you correct the SUI and put the patient on medical management for your urge incontinence. Birth Colpo suspension was gold standard, and TVT procedure was compared to Birch Colpo suspension. There was an easier, less amount of time needed to learn the TVT procedure. Lot of studies initially in 2000, early part of 2000 was done. There were even prophylactic TVTs people have done, especially in cases where patients were athlete and they were leaking, the weightlifters. Then long-term effects were there, and they were similar to that of Birch Colpo suspension. Initially, we had lot of cases, but retropubic procedure was not very common with our fraternity. So what to do? Yes, it was in 2001 that a French collaborators found out a procedure where you could pass a tape which was 20 centimeter from one obturator foramen to the other obturator foramen. They did 56 cases and reported. Madam Maninder, do you know this was copied from a veterinary doctor who wanted to make the female dogs continent. So they devised this procedure, and Delomore copied it into the human subjects, and this was called the transobturator tape procedure. It was safer, faster, more effective, decreased risk of bowel injury, bladder, no retropubic needle passing, no abdominal incision, and only contraindication was pregnancy, UTI, and so if we go and look at the pelvis, this is the obturator foramen, this is the ischiorectal rami, this is the urethra, and in case you are giving a lithotomy position with little external rotation, you are able to feel the adductor longus insertion, which you will be able to feel. So what you see is, this is the obturator canal where the major vessels are there. There are very small arterioles and venous things which goes on the periphery of this bony, the obturator foramen. But this is the safe entry zone where needle could be inserted if it is from outside in, or it could be if it is from inside out, then this is where the needle should come out. Again, if you see the path, it is quite far away from the vessels, from the neurovascular bundles. Diagrammatically, mid-incision is put in, curve dissecting scissor is put, index finger you put in and palpate the lateral margin of the ramus from the skin, and then with the help of needle, you simply push it, attach the tape, and then bring it out. This, again, you put in a curved dissecting scissor or a curved hemostat between the tape and the urethra and tighten it up, and then suture the mid-urethral incision which you had kept in, and cut the tape which comes out from the skin, out of the skin of obturator foramen. So if you see, this is basically uvovaginal sling which is there, which is retropubic, and these are the transobturator tape. This would be the now if you see a normal pubourethral ligament and a monarch tape which is there, a transobturator tape, and you have done an MRI, you'll be able to exactly see that the normal pivourethral ligament basically matches the thing. Unfortunately, these videos, due to conflict of codec, I did one stupid thing of transferring all my data from my Windows laptop to Mac, this thing. So the Kodak is not there. So what happened is transobturator urethral suspension, minimal invasive procedure in treatment of stress urinary incontinence in women, which was done by this French scientist, which was published in Progress of Urology 2001, December publication. And they said that this has the same result as TVT and same as what you call the Birch-Kolpow suspension. Now, when do we do a retropubic procedure and when do we do a transobturator? Friends, the urologists are still interested in doing the retropubic procedures, and our fraternity still loves to do the transobturator procedure. You could even mimic the retropubic procedure doing a transobturator tape procedure if from the wide U which you had seen, the ligament diagram which I had shown in the previous slide, if you take it from little above, then it will also mimic the retropubic thing, but it is the transobturator procedure. There are slings which are now coming up in the market where you operate. You would have seen that many patients do not leak in when the bladder is over distended in lithotomy position, but they give a very pertinent answer that they leak when they are standing and coughing. So what you do is you make them stand, you put one of the left foot on the one of the steps, and then sit down and see and ask them to cough, they would leak. So now tapes are now in the market where you put in the tape, and then if the patient leaks, then you can adjust the tapes. When all these tapes have failed, meaning that if a TOT fails, we need to do a urodynamic study and find out why it has failed. Many a times, patient has diabetic cystopathy and low pressure bladder is there, neuropathy is there, where these procedures would fail. Many times redo procedures, these patients have come to us. Then we have no other option but to put in an artificial urinary sphincter, which comes from AMS company. So artificial urinary sphincter 800 is there, where the bulb is implanted in the vulva, and the entire this is implanted around the urethra. Now you have intrinsic sphincter deficiency, low pressure, the posterior valve is wide open. You ask her to cough, she delivers a huge amount of urine which falls inside the bucket only, which is not spurting. Here you could do a transurethral or paraurethral injection of bulking agents. Only thing is, it's a very easy procedure. Only thing is, these bulking agents are expensive, and their life is between 9 months to 1 year, or 1 year, or 16 to 18 months. So it needs to be redone. So this is what the future of surgery is going to be. The transobturator tape, which huge number of our fraternity is already doing it. I would definitely like to thank Madam Rashmi and all the other stalwarts who are there for patient listening. And I am extremely flabbergasted seeing Madam Maninder Ahuja, Madam, still there. I am able to see her. Also, senior people are there. Sandhya Madam is there. And Varsha is there. Varsha introduced me. Thank you, Varsha. Rashmi madam, thank you very much for putting me up into this webinar. Please share me the link. I will share all the videos. Any one of you wants a learning process, me and Hara are doing it. We have these companies. Nobody has to spend a single naya paisa. We have pharmaceutical companies. I can always tell Corona people to sponsor the local thing. And this is a common problem, just as Madam Maninder has taken up menopause. Menopause is such a huge problem. It is unspoken problem because the woman suffers. She tells to her jethani and she shouts, "Ke ye to hota hai." Mother says, "Ye to hota hai." But yes, since all of you have taken up menopause management in a big way, same way, incontinence, keeping our patients dry should be our goal. Maybe IMS or all the societies which are there, like Amogs has done a big initiative. Let us go and do that. Thank you very much.
Thank you so much. Such a beautiful and exhaustive talk, sir. I would say is Vinit Mishra sir is an SUI man. Beautiful demonstration, and I've seen your videos, sir, TOT and TVT, and I've tried 50 cases of TOT and TVT myself.
Thank you.
Beautiful presentation, sir. Thank you so much for being
Thank
here.
you. Thank you, everybody, for patient listening. But Madam Maninder,
Yes.
you should send us the list of what medicines that should come in.
I have in
India.
mind. I'll send you.
And-
I'll WhatsApp you.
And this
I have your email ID also. Yeah.
Yeah, Corona. Mehta ji. We
He'll
can
do
push
it.
Mehta ji.
Do it.
कि भाई आप लेके आओ. We'll all support.
Yeah.
Mehta ji is an entrepreneur. If we tell them bring this medicine, we'll support. He will bring it tomorrow.
Dr.
Believe me.
Vinit, I am coming for
कल ही ले आएगा.
chairperson elect of ICOG. I am coming for chairperson elect of vice chairperson elect of ICOG this year.
Okay.
But I want to work for FOXY through ICOG now.
Good.
So you all have to support me.
100%.
Yes, madam. Anytime.
Thank
We all
you.
are with you.
Thank you. Thank you.
Thank you, everybody.
Thank you, sir.
Thank you for sparing and listening even late. It is
And we
really
wish all
late,
the
you know.
best to Maninder madam. We
Yes.
wish all the best to Maninder madam.
Yes,
For
ma'am.
ICOG chairperson.
Madam, to best wishes.
So, Suman madam, Sandhya madam, Varsha, Rashmi, Kavita,
Yes, sir.
and Madam
Very nice presentation, sir. Very
Yoga.
clear and we're so relaxed in presenting. That was the best.
Yes, sir. It was very good presentation.
अच्छा लगा ना कि इतना
Thank you.
रिलैक्स हो क्या बता रहे हो ना. That is.
हाँ, एकदम समझा समझा कितना अच्छे से स्टूडेंट को जैसे बताते हैं वैसे एकदम इट वाज सो क्लियर. वेरी नाइस प्रेजेंटेशन.
अरे अभी नीता मारेगी कि सब लोग तुम्हें क्या कहते हैं मास्टर बना दिए हैं.
It was excellent,
नहीं
sir.
अच्छा है मैडम. We have
I'm
done.
so much thankful to my conveners, Dr. Jaya, Monica, Madan, Suyoga, and Sandhya madam, and esteemed chairpersons, Dr. Someshi madam, Dr. Kavita madam, Suman madam, Varsha madam, and Sujit, and respected speakers, Dr. Shaijus, Dr. Parag sir, Dr. Patnaik sir, Dr. Vinesh sir, and Maninder madam. I'm also very much thankful to guest of honor, yes ma'am, Dr. Ambuja Shuranur madam, Dr. Kurtakoti sir, Dr. Pardeshi sir, and Dr. Bipin Pandit sir for all the support, and let us conduct the program under banner of Amogs, and of course not the least Corona Pharma, Cor Connect, Bhavana and Abhishek for their excellent coordination and cooperation. Thank you very much.
Thank you.
Thank you.
Like to
Thank you
Thank
all.
you.
Good
Wish
night.
you all a very happy Holi.
Happy Holi, yeah.
And
Happy
colorful
Holi to
Holi
all
all
of
of
you.
you.
And best wishes to all
Thank
those who are
you.
contesting this time.
Yeah.
Yes.
Thank you.
Yeah.
Thank
Those
you,
who are
Suman ma'am.
contesting,
Best
all the
wishes,
best
madam.
wishes.
Thank you,
And
ma'am.
yeah.
Sir, will you please share the videos on my
Yeah.
Yeah. Yes, sir.
रश्मि आप है ना, अगर कोई ऐसा वो ग्रुप बना देती हो ना, या तो सारे वीडियो आपको शेयर कर देते हैं, आप सबको भेज
रहना
दो।
चाहिए था ना, इसका ग्रुप नहीं बना था। वी
हाँ।
डोंट हैव एनी ग्रुप ना
सर, आप हमारे ग्रुप में हैं, यूरो गाना कमेटी में, उसमें भेज दीजिए सर, उसे वीडियो सब लोग देख
हाँ,
लेगा।
100% मैडम,
हाँ,
ये
ठीक,
अभी
थैंक यू
मैं
सर।
कर देता हूँ, है ना?
या थैंक यू सो मच सर, थैंक यू।
Thank you. Thank you, everybody. Happy
Thank
Holi.
you. Yeah, good night. Happy Holi.
Kavita ma'am,
Happy
Suman
Holi.
ma'am, Maninda ma'am, bye.
Happy Holi.
Good
Thank you.
night.
Bye. Bye.
लीव नहीं हो रहा है ना।